Hello, good afternoon. Hope you are all refreshed after the lunch. Normally, people get duller after the lunch, but I believe you are all ready and set to go for the next session, which is a bit power packed, one after the other. But throughout, the coffee is available anytime. Our next session, next two sessions, will be chaired by Dr. Fakri Aldeep, as a very known intervention cardiologist. I call upon Dr. Fakri Deep on the dais. Please, Dr. Fakri. Dr. Unni Nair. He is well known here in Dubai. He is internal medicine, great physician in our Medcare Royal Hospital. And Dr. Sachin Upadhyay. Dr. Sachin is a consultant cardiologist in Aster Hospital, Dubai. Please, Dr. Sachin. And so you will be chairing two sessions, session 7 and session 8. And needless to say that, so one of them for you, just to inform you that 3:05 to 3:20 session will be online. Other speakers are present here. And the timing, that is all, please, you have to maintain. That's all. Thank you so much.
Thank you so much, Dr. Mittal, for your kind introduction. It's my pleasure to co-share this session together with my dear colleagues. I know Dr. Mittal since 2 decades, right? 20 years since he was a senior registrar coming to the private sector for the first time. I have been with him in this meeting for year after year. I think I missed it only one time. I had to travel for urgent matter, So from the beginning of knowing him, he was a very dedicated cardiologist, When he wants something, he does it, and this resilience and this insistence, made the success he had in this meeting. I would like to congratulate him for a very good meeting, excellent meeting, became one of the landmark meetings in the area. I would like to invite our speaker, Dr. Abdul Jabbar, to come to the podium to give his presentation about dyslipidemia management, up-to-date 2026 evidence, targets, and therapeutic strategies.
Thank you for the kind introduction. For the sake of time, I should run to the stage because otherwise you'll remove me from the stage. Thank you, everybody, and thanks a lot to Dr. Mittal and Shakeheart organization to give me the opportunity to participate with you in this session. These are the very important messages coming. I always say the very purpose of Shakeheart and everything is to prevent the cardiovascular adverse effect or cardiovascular events. But the important message for all of us is there are multiple risk factors, but the dyslipidemia is one of that, which is usually silent. It doesn't give you any symptoms. So among the various risk factors, diabetes, blood pressure, obesity, everything once getting above a threshold will give us symptoms and ask the patient to go and see the doctor. And when we prescribe the medication, and if they stop taking it, they will learn that it's not working. They will have polyuria, they may have weight loss, they have increased thirst, they have headaches, something like that. But unfortunately or fortunately, with dyslipidemia, this doesn't hold true. Many of our patients can check their blood sugar and blood pressure at home, but they're not checking their cholesterol at home. So they don't feel anything unless the doctors educate them. I give this same message when I talk about the kidney disease. It doesn't tell you your creatinine is going up unless you check it. So this is something in the domain of the doctors to convince the patient that this is important. So as mentioned, dyslipidemia is silent in symptoms. So it teaches us to act before the event happens, because when the event happens, it's too late. Every elevated LDL is an opportunity, and every missed target, although the patient may be on the medication with statin whatsoever, and he or she may be feeling, oh, I'm already taking my statin medication, I'm very regular about it. But nowadays we are learning it's on to the target. If it is not on the target, still the purpose is not achieved. The management is not the question whether to treat or not, but nowadays the question is how aggressively to treat. So it's not a routine medicine, it is a preventive cardiology. And although Dr. Mittal, my good friend, and many of them, I say the objective of us is to prevent the patient from going to cardiology. And that is the important message which I always give. As you can see here, there are various factors, modifiable and non-modifiable. So now look at the modifiable risk factors: elevated blood pressure, diabetes, LDL cholesterol, obesity, physical inactivity. Which one is the easiest to manage? Not by your patient or by you or by anybody. Which one is the easiest to manage? Physical activity is the most difficult. We say it's easy, patients say it's the most difficult, I don't have time. Yeah, LDL, because dyslipidemia, all you need is to take the medicine as advised by the doctor. And in majority of the patients, fortunately, we have got such a big dimension of the medications available that if you get a side effect with one, you can go to the other one. So people used to say, oh, this and that, because they believe in the open label studies published on the social media. But the social media gives you the picture of 1% of the patients who got some side effect, which happens to any medicine. But 99% who are getting it, taking it, and not having side effects, they're not writing on the social media, I'm feeling very good, because they don't feel anything. It is an asymptomatic problem. So important thing with the new guidelines is there are various risk enhancers like family history. So when you see a patient whose LDL is above normal, you must ask the family history, not only of the dyslipidemia, but also for diabetes and the risk of or already the events happen in the family of the cardio event or cerebral event. A continuously elevated LDL greater than or equal to 160. Nowadays, the new momentum in terms of measuring the elevated lipoprotein, CKD, diabetes, metabolic syndrome, inflammatory diseases, South Asian ancestry, and also on the top of it, elevated triglyceride. So these are all risk enhancers. How do the risk enhancers help us? So in a busy clinic, you may not be doing the prevent calculator or a scope calculator or a scope 2 calculator or scope OP calculator, but this gives you a picture, is this high risk or not high risk? So many of my patients, maybe many of yours as well, they are diabetic. So if they are diabetes patients, they are high risk or low risk? Yeah, not even moderate risk. So the numbers you want to see what target to achieve is clear. You may do the calculation, which is very useful, but even if you don't do the calculation, they are high risk. So as we can see, the post-statin era is arrived. When the statin came, we were worried which one statin to use, which one to not to use. But now we have learned, as we did for everything, that even if the patient is on a statin, there are significant 30 to 40% of the patients, they are not on target. Their LDL cholesterol is not where they should be. So the next step has to be done. So either you go step-by-step approach, but as you have learned for the other chronic metabolic diseases, hypertension, diabetes, everything, we don't start with one and keep increasing the dose. It's better to start with combination or add the combination as soon as possible to achieve the best results, achieve the target with minimal side effects. And the important thing is, like in diabetes, we say in the same way in the dyslipidemia, the early, the better. The clinical inertia should not be there. Fortunately or unfortunately, our laboratory reports don't tell what is the target for this patient. They don't tell this patient has hypertension, dyslipidemia, or family history or not. So they will write the normal LDL is between 130 to 160. Sorry about it. So patient, they look at the reports and they say, oh, doctor, why are you asking me to increase more? So we have to educate the patient. Your number should be right to prevent more events in your body and in the future life. As you can see, both the things are important, the magnitude and the duration. If the LDL cholesterol is 130 for the 10 years time or 160 for 2 years time, they may be equally riskful. So you have to bring the numbers for the individual patient's risk assessment and then to bring it where it should be. Many of the patients are very, very reluctant. And that's why my first question was, it's the easiest to manage. The first thing is the physician should know the target. If physician says, your LDL cholesterol is 92, you are normal. The most common message I get from my patient is, my doctor said your LDL cholesterol is borderline. Can you define what is borderline? There is no such thing as pre-diabetes in dyslipidemia, right? So what is borderline LDL cholesterol? Or what is borderline cholesterol? The first thing which happened from where? From the doctor. He didn't say what is your target, you say your borderline. Right? Every patient has a target. If it is good, low, you below 100. If it is moderate or high, below 70. If it is a previous event and the high risk, less than 55. You should tell them upfront, this is your target. Most of the patient will say, I don't want to take statin because of this and that. And you cannot impose to the patient. You have to check with them, what will you do? And I'm surprised that many of the patients coming to me, I ask them, what will you do? What will you stop eating? I don't know. They've been treated by doctors. They haven't told them what foods has got. And you will ask this, any patient you ask, what foods have cholesterol? What is their answer? Fried food. Now you tell me, is it correct or not? Fried food has cholesterol? Many of the doctors don't know. Correct, right? Fried food has cholesterol? Yes or no? Why? Why? Because they are mostly fried in vegetable oil, not in the animal oil. If they are fried in the animal oil, they will have cholesterol. So cholesterol major source in our food is animal. So most of the things being fried today are not in the animal fat because it's more expensive. So vegetable fat has got a lot of triglyceride, but not cholesterol. So now I will show you the important message. Earlier is better and stronger is better depending on the patient risk. You have seen this slide maybe earlier today as well. The guidelines say, what about the moderate risk, high risk, very high risk? And as I said, all of our patients mostly are, if they are diabetes, target organ damage, they've got blood pressure, they've got early onset of type 1, they've got a family history, they are high risk or very high risk. And what is the level to be achieved? Either less than 70 or less than 55. What is happening? The recommendations are saying lipid lowering therapy in patients with acute coronary syndrome should be started the day they are admitted. But many of the patients, they are already on the statins. What should you do? Already on the statin, whatever is their LDL cholesterol, still they had the event. That means they should be intensified, whatever treatment they're taking. Here the target changes. Even if the patient was below 55 and still got the attack, that means there is something. I cannot go into the details. Cardiology colleagues will do that. Then you have to go for the LPA and apolipoprotein and things like that, because having an LDL in control doesn't answer the question. The second thing is, if you want to utilize the combinations nowadays available, as we do that, I often talk about diabetes and I say it's foolish to start on metformin alone. Although guidelines say that, but it depends. You're not treating a patient with an A1C of 6.1. You're treating a patient more than 6.5. So you always go for combination. So if the LDL cholesterol is high, where it is, it depends on that. Should I start on the statin alone or I should combine it with something else? The easiest combination nowadays available is to combine statin with ezetimibe, and one of the potent one is rosuvastatin. You can combine with that even in the treatment naive patient, so that you achieve the target quickly and you maintain the target longer and the side effects are less, the adherence is more. So successful lipid lowering in the post-acute coronary syndrome patient should be effective implemented early, and sustained with good adherence. So the key guideline strategy risk is early intervention, early detection. Any very important, some of my patients, I ask them, if you've got a kid above 15 or 20 years of age, check their cholesterol now. But many of the things, mixed hyperlipidemia is very common in the family. And they don't check till they develop blood pressure, or they have some symptoms, or somebody have coronary, or the father has coronary, and the child will now go to the hospital and say, oh, let me check my cholesterol as well. They should be checked early. Early intervention is fruitful, it helps, and it's the preventive cardiology. We should go for the new risk assessment tools and the risk enhancers, if available and your insurance is approving, better to check ApoB, LPA, CAC, and CKM syndrome. So new risk categories, as I say, but majority of our patients are high risk or very high risk. So we should be working on that. So the secondary prevention in which the patient has had a cardiovascular event or cerebrovascular event, useful lifestyle, high intensity statin therapy, try to reduce LDL cholesterol by 50% from the baseline to a goal of less than 55 milligram. As the guidelines say, add ezetimibe or NTP-PCSK9. So that's where I'm coming. NTP-PCSK9 is not easy. It's not approved. It's expensive. It's injectable. But ezetimibe is one of the easiest one available in the combination now, which you should not wait. And it gives you an opportunity to use a lower dose of statin so that the chances of having a side effects is low. This slide is very, very interesting. I was not knowledgeable about this risk. Look at the patients. The green is all patients. The blue is patients on lipid lowering therapy. And the pink or red is not on lipid lowering therapy. The low risk patient, 66% not. But moderate and high risk, 47 and 27.3% of the patients are not on lipid lowering therapy. Who is the blunderer? Where is the blunder? Why are they not on treatment? Obviously, there are only two answers. The doctor didn't prescribe, or the doctor prescribed and the patient is not taking, right? But as I said, if the patient who needs insulin or diabetes medication is not taking, he will come back to you in 1 or 2 months. He'll have symptoms, he'll have problems. But the patient with lipids, if he's not taking, and sometimes if he's not taking and his blood pressure goes up, he goes to the doctor will adjust his blood pressure medications. So this is unfortunate and it's happening. The second one is the blue line. The patient is on the lipid lowering therapy, but not on target. He keeps going to the doctor every 3 months and the doctor says, your cholesterol is good. Right? There are two ways. If he's not listening to you, send to cardiology. But if you're a good doctor, you should listen to them. He should listen to you. So this slide shows the incremental as we do. We increase the dose of a statin from 10 to 20, 20 to 40, 40 to 80. This is showing the rosuvastatin, one of the high intensity statin, in which the dose was increased from 10 to 20, 20 to 40, as opposed to from day one you started the combination. And the data which is shown in the study is very, very useful and eye-opener. If you up-titrate from 10 to 20, what is the additional LDL-C reduction? -6%. But if you start the combination with 10 plus 10 of ezetimibe, the reduction is 24%. Very easy achievement, very simple to do, with a single pill, less chances of side effect. And our patients have got in the mind. If you explain to them, look, I'm not increasing your statin for which you are worried about the side effect. I'm giving you something else which does not work on the muscles, which doesn't work on the liver. The way it works is to prevent the absorption from your gut, the extra cholesterol which is lying in your intestine. They will listen. And in some patients, when the levels is not very high, they are low risk, they are not tolerating, I use ezetimibe alone. But in this group of patients, not to start ezetimibe right from day one is a mistake. About the safety profile, moderate intensity plus ezetimibe group, as you can see, in terms of the patients which discontinue, the high intensity, the discontinue rate was more than in the combination group, again, for the reasons I've already mentioned to you. So the proportion of patients, for any reason, if you give medicine separately as opposed to one pill. We always know the combination adherence rate is better, but because of the side effect and other things as well, we see from the data published here that the adherence rate was 75.2 compared to 50. So about 25% more adherence in patients who are using combination as a single pill combination. So in summary, the rosuvastatin ezetimibe visited coming to you, Lipocom, it has got minus 63% LDL cholesterol reduction, four times more than the statin up titration. We've got the confirmed cardiovascular protection and about 2 times more adherence. So all challenges we face in the dyslipidemia management are not easy. They need your patience and education to the patient as well to keep reminding them, to keep checking them, and to try to focus on the target to be achieved. The problem is the patients are remarkably undertreated. There is a clinical inertia and underestimation of the risk. Combination therapy is underutilized. We can overcome the earliest usage by simple and effective approach, overcoming the clinical inertia. The guidelines say upfront therapeutic approach in a very high risk and high risk patient, and greater cardiovascular event reduction than the monotherapy in his, and good safety profile and better adherence is available. It fulfilled the needs of early, strong, and sustained LDL cholesterol lowering. Thank you very much. Happy to answer any questions.
Can I take? Nice talk, Dr. Jabbar.
You take questions later?
Yeah, I think we have
Now? Okay.
time, yes. Just now we have, come across from the beginning of the years, like we have the Framingham scoring, then the score system came. Now we are hearing the preventer scoring. So what is the real advantage of this newer and newer scoring? Is it making any difference?
I didn't get the first part.
The Framingham scoring, then the score system which the European Society came. Now we have the prevent, the new one. What's the real need? Now I'm hearing you have a 10-year, then it's a 30-year.
Very good question, and that was my answer. That the scores come and how many times we calculate and how many times you implement it. And that's why I say in summary, you have to just take the patient history, the family history, and the previous event. That gives you the answer. Some of our patients nowadays are educated by
Google.
ChatGPT, right? So they will say, oh, doctor, ChatGPT says you don't need this high dose. Then we should have something referenced. And if you put the patient, take this reference, put in the ChatGPT, he will tell you you need it. So this is something I think coming now. Now, the second part is, as I said, many young patients, either by the doctors or their families, are getting educated. They check their LDL profile. And as I say, because the range written on the report is 130 to 160 is optimal, or 100 to 130 is good. So they question it, and they are not symptomatic. So for them, assessing a 10-year or 30-year risk from the prevent data will show, look, you don't have anything now. But based on the calculation, in the next 30 years, you may have these events, and taking a pill which has got minimal side effects is not difficult. I give them the second target. I say, okay, let's wait for 2 months, 3 months. You do your best. We achieve your levels. If you don't achieve level, then we will start. If you achieve your levels, we don't give.
Between the previous scores and prevent are: first, obesity was not included, which has been included. Diabetes is a very important risk factor. HbA1c was never included in any score, included, as well as anti-diabetic treatment. Urinary ACR, which is a marker of inflammation, not only for CKD, for CVD. So urinary ACR has been included. eGFR, patients of CKD have 4 times risk of CVD. They don't die of CKD, they die of CVD. So that has been included. So this is a much more comprehensive score, gives a better estimation of your overall CV risks than the previous ones.
Thank
Any question
you.
from the audience or any comment? If not, then, sir, I would just like to ask, like, do you have any, like we know that nowadays it is combination therapy which is recommended. the sooner, the lower, the earlier, the better, and all those things. So in what percentage, like in your practice, do you think we start rosuvastatin at the outset or rosuvastatin alone?
So in my practice, aside from the scores, I look at the numbers as well. So number one, nowadays, even though I'm not a cardiologist, we use LPA as well. So LDL, if LPA is high, that means it needs more aggressive. So from day one, it will be on the combination. Somebody, as I said, is very high risk and his blood LDL cholesterol is 135. Then I won't wait for statin alone and to see after 3 months and 6 months, I will start. If somebody is 95 and I want to bring it to below 70, I will give this opportunity to start with statin alone and they'll see the results. So it's very much 1-to-1 rather than the rule.
Yeah, that is what is the, for the general audience, I wanted to highlight, and that's why I asked that question. Now that don't wait for the step ladder pattern, and we need to be mindful of the numbers, mindful of the risk. And if we believe the number is high or the risk is high, you start immediately the HDM. I not wait for the step ladder up titration. Yeah, thank you.
Thank you. Very correct. So I will say that emotional connections are important. So emotional connections, who in your family had heart attack? My father had heart attack. He was on his medicine. He was already on medicine. So now it's better for you to be on medicine and to be on the target. Being on medicine doesn't solve the problem. You were asking something? Or
I just wanted
Should
to.
close. I'm so sorry.
Okay.
We are already delayed by.
yes, thank you.
Please don't do this.
We'll talk later.
Yes. So we are already delayed by 10 minutes for the next session. I'm sorry. Yes. So let's start with the next session.
Yeah, sure. I would like to invite now Dr. Amrish Agarwal, who will be talking about the resistant hypertension, existing and emerging therapies. Dr. Amrish Agarwal, please. Dr. Amrish is a senior consultant cardiologist, Fujairah Hospital, UAE, and an expert on preventive strategies in cardiovascular disease.
Good afternoon, everybody. It's very difficult for the government sector to remain awake at 3 o'clock, but we'll be awake till 6 o'clock, 7 o'clock in the evening. This time, Dr. Mittal called me and he said, can you speak on hypertension and resistant hypertension in particular? We had some talks before which focus on the hypertension component by itself. My colleague, Dr. Tayari, spoke on telmisartan. And today we are going to talk a little about resistant hypertension. The reason is that despite all the efforts, we are not able to treat the hypertension properly. Number one. Number two is that over the time, we know that even a small difference in the blood pressure reduction, even in systolic and diastolic, cause a meaningful reduction. For example, if you lower the blood pressure of 5 or 10 millimeters, you can cause nearly 20% reduction in the cardiovascular outcome. So it is a very simple strategy to prevent common condition across general population to reduce the cardiovascular risk. Despite the best effort, despite using multiple medications, and despite using combination therapy, the fact remains that even in America, and this data regarding America is true across all the world, if you say the lower bottom, that many of the patients don't have blood pressure control more than 140/90, despite using multiple medicines. So the multiple medicine is the one which determines a hypertension from a normal hypertension to a resistant hypertension. And the universal accepted definition is that a blood pressure which is more than 140/90, despite using 3 medicines, and one of the medicines should be diuretic. So that means what? You should attack multiple components of the hypertension genesis. We are talking about vascular, we are talking about diuretics, and we are talking about the RAS system. So all the things to be attacked. And if the blood pressure is not controlled by the maximum tolerated medicines, then we call it a resistant hypertension. But there are some nuances. For example, if you give somebody 4 medicines and the blood pressure is controlled, we call them controlled resistant hypertension. And for that matter, if somebody gives 5 tablets, medicines, and the blood pressure not controlled, we call is a refractive medicines. Now, this situation is very common. It happens to all of us in the clinic. So when a patient who comes with a blood pressure not controlled, the first thing a clinician has to look multiple variables. When we say clinician, we're talking about all the people in the room, but the 3 things stand out among them. One is salt consumption, which is an important component, obesity, which have been highlighted before, and the sleep disorders. Once we excluded these 3 common conditions and many more, we are left with very important condition to be excluded, which is what is the adherence and what is the compliance of the medicines. This is very important because despite using combination therapy in the single pill tablet, whether we talk about dual tablet or whether we talk about triple tablet, the data historically show across the word that many of the patients, they don't take the medicines because the hypertension by itself don't cause any symptoms. So the data show that nearly quarter to half of the patient, they stop the medicines within 1 year. And so poor drug compliance is a very important component before you label the patient as resistant hypertension. That is why if you see the European Society of Hypertension guidelines for 2023, it emphasizes that most of the people for the hypertension should be given multiple drugs in a single pill combination. We talk about dual combination therapy and the triple combination therapy. And when you have this time of this, we are able to actually control the blood pressure in nearly 80 to 90% of patients, leaving a small subset of patients where the blood pressure is not controlled. When you reach this category, when the blood pressure is not controlled, despite using a triple combination therapy, one needs to confirm that this is really uncontrolled blood pressure by using ambient blood pressure recording at home or home blood pressure monitoring. Verify adherence. You can use multiple things. You can use the pill count. You can talk about the box contents, and you have to exclude secondary hypertension by ruling the renal vascular hypertension and the renal parenchyma hypertension. Once you reach this stage and the blood pressure is not controlled, then we need to add some more class of medicines. And typically, this classes of medicine can be divided into 3 classes. Either it attacks the sodium or fluid retention, or it causes activation of SNS system, or impaired vascular function. So we are dealt with the calcium channel blocker, we talk about the RAS inhibitors, and the diuretic. And that is why the European guidelines, they say that in true resistant hypertension, we should consider spironolactone, beta blockers, alpha blockers, or scintillating drugs and amiloride. And these are the level 2 recommendations for the patient with a true resistant hypertension. Now, among all these drugs, if we have to choose one drug, which drug we will choose? And the general consensus among the cardiology community, and for that matter globally, based on the data, is that the 4th drug should be spironolactone. And this data has come, very strong data came from Pathway trial, in which they pitted spironolactone against multiple other drugs. They pitted against beta blocker, which is bisoprolol, against the alpha blocker, and pitted dexamethasone, and they found that actually spironolactone is more powerful than any of the drug among the class. It was no difference in adverse outcome, and the spironolactone 25 to 50 milligram was more powerful than doxorubicin and bisoprolol. So the first recommendation is that the 4th drug after triple combination therapy should be spironolactone. But do we really prescribe spironolactone? Are our patients really adherent to spironolactone? For this, the answer is debatable, because the historical data shows and multiple studies that the clinicians' uptake for using spironolactone in the practice is not very common. Typically, less than 25% of patients, and they receive spironolactone. And if you see on the right-hand side, you can see that even despite 100% patient initiated spironolactone inside the hospital, there is a poor adherence in the outpatient. So many of the patients, nearly 75% of patients, they stop spironolactone. And because multiple reasons, one of the reasons is that spironolactone is a non-steroidal, is a steroidal melanocortical receptor antagonist. It causes gynecomastia, it causes decrease in the libido, it causes hyperkalemia. So there are many side effects, and then no pharma company is supporting spironolactone. So the patient and the physician uptake for spironolactone is little bit on the less side. So, and what do the guidelines recommend once you reach the stage of spironolactone or the patient cannot take spironolactone? The guidelines, they talk about multiple other therapies. They talk about renal denervation. So the renal denervation is a very good class of treatment. Or treatment is not a pharmacological treatment, it's an interventional treatment for the people whose GFR is adequate. The GFR for the renal denervation should be more than 40 or 45 ml per meter square. And it's very important that all the current guidelines, where we take up the European Society guidelines for 2023, we talk about the European Society 2024, or the American College of Cardiology guidelines and 2025, all these 3 guidelines that talk about using renal denervation in the uncontrolled hypertension and the resistant hypertension as a 4th floor for hypertension. But the recommendation is not class 1, not class 2, it is class 2B. It is a technically simple procedure. It's a very big artery. The people who work in the coronaries, they can reach the renal arteries very easily. And the old times when we were doing angiography, all the patients who had angiography, we will do a renal angiogram, particularly their hypertension, before closing the procedure. So this is because the sympathetic nervous system which supply the kidneys, they actually have a pathway which reaches the kidneys to the adventitia of the renal arteries. So this can be ablated by radiofrequency ablation. And nowadays, more contemporary technology involves ultrasound ablations. And these nerves, when they are ablated, they decrease sympathetic inflow to the kidneys and thereby attacking the process of the hypertension. So there are multiple trials which will be done over time against the sham, against the ultrasound versus the renal denervation. And in one meta-analysis, which include 30 randomized trials with nearly 2,285 patients, they found that ultrasound guide-based techniques are a little bit superior than the done with the renal denervation. And you will find that the office blood pressure and the home blood pressure are marginally better with the ultrasound and derived technique. So what is the utility in the current era? If you look at the position paper, if you look at the paper from 2025, American College of Cardiology guidelines, they say, and this is the text I have taken from there, that the some trial show a small, but a significant reduction in the 24 hours ambient blood pressure. By how many millimeters? By 3 to 5 millimeters. Well, something is better in resistant hypertension over the STAM trial, but other failed to reach the primary endpoint. And unfortunately, there is no way for us to predict which patient will improve and which patient will not improve. It's only the procedure will find out that this patient did not have any change in the blood pressure. And in editorial by Mesrili, who is known for his sarcastic tone, he said, what is it is a therapy or is a gizmo idolatry? Why? Because the people who can do it, they're very passionate about it. And this is also partially supported by the industry. And he said, while the therapy's curative effects are uncertain, but the theateristic that I did the renal denervation and the patient blood pressure become cured, even in placebo also, it could have the same effect, are undeniable. So in 2024, the American College came with a scientific statement of renal denervation. And they said, most of the patients, but not all, they reach the primary endpoint, demonstrating a modest efficacy of renal denervation in lowering the blood pressure therapy, but the individual responses vary, and the further researches are necessary to identify for those who will benefit more. So once again, it is beneficial by a couple of millimeters, and 1/3 of the patient will not respond. There is no way for us to know who will respond and who will not respond. So coming back to the pharmacotherapy, there are some more exciting new lines for treatment. And one line is the treatment which is aldosterone synthase inhibitor. Aldosterone synthase inhibitor, we are going to have a separate talk in the next speaker, so I will not encroach on it. But the thing about the aldosterone synthase inhibitor is that people are thinking about it for more than 50 years. But why we could not succeed from the pharmaceutical point of view? Because the enzyme solubility between cortisol synthetase and the aldosterone synthetase are remarkably similar. There is a 93% sequence homology because aldosterone synthetase is nothing but CYP11B2 and the aldosterone synthetase is CYP11B1. And now we are able to synthesize this molecule in a potent way, which can affect only aldosterone synthetase without affecting cortisol synthetase. And these molecules have come in production from 2022 onwards. There are 4 molecules. Yesterday was the launch meeting with baxdrostat, but there's lorundrostat, there's becarodostat, and baxdrostat. Among them, I think the first 2 molecules are the ones which will come in the pipeline down the line. And baxdrostat among the molecules in the phase 1 and phase 2 trial showed a remarkable reduction in the urine aldosterone secretion without any impact on cortisol. So direct affecting aldosterone reduction, synthetase reduction without affecting any cortisol. And then in the pivotal trial and the phase 3 trial, it was able to show a reduction over the placebo. So this is a placebo-corrected reduction of nearly 8 to 9 millimeters of mercury. We can see a reasonably powerful reduction with the side effect of MRAs, which is similar to spironolactone. It causes hyperkalemia. So it is nothing but an spironolactone, a little more upstream action. So it is acting at the level of aldosterone synthetase and having the similar side effects, not similar, side effects on hyperkalemia similar to spironolactone, but very little effect on, no effect on libido and gynecomastia. What about other pathways? There are certain other pathways which are in production. One of them is aminopeptidase inhibitor, which are actually located inside the brain, and they prevent the conversion of angiotensin 2 to angiotensin 3, which is centrally mediated mechanism for hypertension. So these drugs are in production, are in active pipeline, and there are phase 2 trials going on. Second class of drug is called as the MNAP, which is nothing but M-atrial natriuretic peptide. So it's a synthetic analog for ANP. It causes very good diuresis, causes blood pressure lowering. And when compared to placebo, it can lower the blood pressure by 30 millimeters of mercury. But currently, there is no oral form, has to be given in injectable form. So there is a molecule of febuxostat. This is under production, and there are phase 2 trials going on. In addition, the current molecules which are going now are two areas which are very, very important and very similar to inclisiran molecule, which is current production. These are the RNA therapies. One of them is the cRNA therapies, which is small interfering RNA therapies. The small interfering RNA therapies are also conjugated like inclisiran to GalNAc molecules. They enter the liver, they are selectively absorbed by the liver and prevent the production of hepatic angiotensin. So it is acting very, very upstream in the renin system pathway. Actually, when you give them the molecule as single injection, it can knock off the production of angiotensin by nearly 50%, and the effect are durable. They last for nearly 6 months. This molecule called as zilebesiran is undergoing phase 2+ trial. We can say the phase 2 trials are completed and they're enrolling patients for phase 3. And there's another molecule which is acting with the antisense oligonucleotide, which is from the INEOS AGT LRF4 trial. This particular molecule, the further trials are halted, and this is not halted because of safety issue or something. The company had the funding issue, they stopped the development. So as of now, it appears that the small interfering RNA therapy is going to be the future for injectable therapy for hypertension. So durable action over every 6 months. With this, I come to the end of my talk, leaving 1 minute for questions. I'm happy to take any questions which you have. Thank you very much.
Thank you so much, Dr. Amrish. Excellent presentation as usual. Always new things you bring.
May I suggest, because the online
I know.
speaker is available now. So
Yeah,
better
we will leave
his
the
lecture
discussion at the
and
end.
we can have
Yeah.
discussion. Thank you.
Yeah. So I assume the next presentation will be virtual, right? So okay. So it's my pleasure to introduce our next speaker, Professor Claudio Borghi, Professor of Medicine at the University of Bologna, Italy. I had the pleasure to attend his lecture last night in the launch of Baxdrostat, and we are looking forward to learn more from him regarding this new molecule, which is an amazing molecule, which will definitely be an asset in the treatment of hypertension.
Hello to all of you. First of all, let me thank the organizer of this Shakeheart symposium for the invitation. This is a beautiful view of my city. One of the characteristics are the porticos, and we have many kilometers of porticos. So if you come to Bologna, you can walk through the city, even if it's raining very hard. These are my personal disclosures. These are the disclosure of the company. And actually, let's move to the topic of my presentation, that will be hypertension, which is the most important risk factor for cardiovascular disease. As you know very well, in the world, more than 1.4 billion of people is actually suffering from hypertension. And this is responsible for a very high rate of cardiovascular and renal disease. In particular, one of the most important points is uncontrolled hypertension, which are the patient with blood pressure is treated without achieving the target of blood pressure control, which is responsible for an extra increase in the relative risk of major cardiovascular complications, including myocardial infarction, stroke, and renal disease. Actually, the solution, you know very well, is the reduction in blood pressure. And the results of these and many other meta-analyses are clearly shown that for any 10 millimeters of mercury of reduction in systolic blood pressure, you can achieve a remarkable reduction between 20 and 30% of the relative risk of mortality and major cardiovascular complication. But actually, if you look at the real world, you will see that this benefit is not actually achieved, and the extent of blood pressure control in the general population is much less than expected. This is the most recent review of this topic. You would see that over time there was an improvement in the extent of blood pressure control, but still we have more than 60% of the overall worldwide hypertensive population, which is not under control, which are worse result in the low-income countries. So actually, this is largely due to the high prevalence of uncontrolled hypertension. And according to this very nice paper published a couple of years ago, you know that the remarkable proportion of treated patients are actually uncontrolled, and the uncontrolled number of patients with hypertension is close to 300 million across the world, and they increase significantly the rate of cardiovascular disease in the general population. What we should do in this population, the European guidelines, like many of the other guidelines across the world, are suggesting probably three main solutions. The first one is the renal denervation, which is not so practiced, so we'll not talk about the renal denervation. The most relevant is the extensive use of combination of antihypertensive drug, which should be mainly based on the presence in the combination of drugs inhibiting the renin-angiotensin system, either ACE inhibitor or ARBs. And one of the most relevant solutions is, however, the use of MRI, in particular the use of spironolactone, which is suggested according to the result of the Pathways 2 study that works very well in uncontrolled and resistant hypertension. However, if you look at the pharmacological profile of drug inhibiting the renin-angiotensin system, you can clearly see that for all of them, there are some specific therapeutic limitations. For ACE inhibitors and ARBs, the main limitation is some kind of aldosterone breakthrough. So when you treat the patient with this drug, you can have some escape of the aldosterone system that can reduce the impact in terms of blood pressure control and prevention of cardiovascular disease. But even for MRA, for spironolactone, there are some specific limitations. First of all, because the treatment with MRA increases the level of aldosterone. The second is that such increase in aldosterone can stimulate mineralocorticoid receptor independent effect that we will see are very important in terms of genesis of cardiovascular disease. And finally, the MRI of steroidal structure like spironolactone have some remarkable adverse effect that makes the drugs not very well accepted by the patient, leading to a very high rate of discontinuation that can significantly reduce the impact of this type of treatment in this population of patients. In particular, the aldosterone receptor inhibitors are not able to block what we call the non-MRA mineralocorticoid receptor mediated aldosterone effect, the so-called non-genomic effect, which are based on a specific and direct interaction of aldosterone with a different tissue, particularly at the vascular level, at the vascular smooth muscle level, at the endothelial level, and at the fibroblast level, which is responsible for the onset and the progression of target organ damage. And you know very well the target organ damage affect negatively the clinical outcome of hypertensive patient, regardless of the extent of blood pressure control. This means that we need new perspective for the treatment of uncontrolled and resistant hypertension. These new perspectives are certainly, one of these new perspectives, the most important, is probably represented by the use of aldosterone synthase inhibitor, a very peculiar class of antihypertensive drugs. The mechanism of action is very simple. Aldosterone synthase inhibitors are blocking the production of aldosterone by selectively inhibit the enzyme aldosterone synthase, thereby reducing the level of circulating and tissue aldosterone. From the pharmacological and pathophysiological point of view, this is a great achievement because the blockade of the production of aldosterone will translate into a blockade of the negative effect of aldosterone, both those related to the interaction of aldosterone with the receptor, those who are independent from mineralocorticoid receptor, thereby reducing significantly the negative impact of aldosterone on the cardiovascular and the renal system. The clinical efficacy of aldosterone synthase inhibitor has been recently reported in a large meta-analysis involving all the published study, which is involving more than 2,000 patients with uncontrolled or resistant hypertension with blood pressure more than than 130 over 80, despite a stable treatment with two or more antihypertensive drugs. In this case, all the studies have been randomized against placebo. The most important point is the extent of blood pressure reduction observed in the general population, that is about 7 millimeters of mercury for systolic blood pressure and about 2 millimeters of mercury for diastolic blood pressure, which is pretty interesting because you know very well this is the extra reduction in blood pressure you can achieve beyond the clinical efficacy of the background treatment, which is usually based on 2 or more antihypertensive drugs. Actually, among the aldosterone synthase inhibitor, probably the most interesting and the only available on the market is baxdrostat. Baxdrostat is a very selective inhibitor of aldosterone synthase, which is able to blockade the aldosterone synthase without any impact on 11-beta-hydroxylase, which is the enzyme which is responsible for the production of cortisol. The extent of selectivity between the two enzymes is about 100/1, which means that the drug is able only to block the production of aldosterone without infecting all the other adrenal compounds. The clinical efficacy of baxdrostat has been tested in 3 major randomized clinical trials. The first one is a phase 2 trial called the Bright Hypertension, and has been carried out in patients with treatment-resistant hypertension by testing the clinical efficacy of blood pressure controls in a dose-dependent fashion in this very interesting population. And the results you see are pretty clear. There was a significant dose-dependent reduction of both systolic and diastolic blood pressure that was achieved very rapidly after the administration of the drug was maintained in a dose-dependent fashion for all the period of observation. Of course, this improvement in blood pressure control was associated with expected changes in the neuroendocrine profile, with a reduction in the urinary aldosterone excretion, a significant dose-dependent reduction in serum aldosterone, a concomitant increase as expected for feedback mechanism of plasma renin activity without any significant decrease in the level of cortisol, which means exactly that the drug is pretty much selective for aldosterone synthase. But I think the 2 studies that represent the clinical efficacy of baxdrostat that can be used just to address the use of this drug in clinical practice are 2 phase 3 trials. The first one is the BAX hypertension, and the second is the BAX 24 trial, carried out in patients with resistant and uncontrolled hypertension. The BAX hypertension study has been carried out in a large population of patients with treated with at least 2 antihypertensive drugs, not achieving blood pressure control despite this strong antihypertensive treatment. The patient has been randomized to 3 different arms, baxdrostat 1, 2 milligrams, and placebo. What is interesting is that the primary endpoint was a reduction in systolic blood pressure that was achieved in patients already treated on a background therapy, including ACE inhibitors and ARBs, as I mentioned before, in over 90% of the population, while 70% were treated with calcium channel blocker and over 30 treated with a beta blocker. This is the extent of blood pressure reduction in response to the different doses of baxdrostat. You see a huge decrease in both systolic and diastolic blood pressure that was comparable in the overall population. What is interesting beyond the huge blood pressure control was the fact that in the trial there was a short phase of withdrawal of treatment, and you will see that during the withdrawal of treatment, the blood pressure control remained below the baseline level of blood pressure at the beginning, while in patients treated with placebo, there was a small and significant increase in the level of blood pressure. In terms of population, since the study included both patients with uncontrolled and resistant hypertension, you see that the extent of blood pressure control was exactly the same in patients with resistant hypertension, which is a very important population that didn't have a specific and effective treatment so far. Actually, if you look at the extent of delta, the blood pressure decrease for the two treatment, you will see very interesting result in the Bach's hypertension trial with a reduction in systolic blood pressure that in absolute term was around 50%, 50 millimeters of mercury in patients treated with 1 milligram, over 15 millimeters of mercury in patients treated with 2 milligrams, with a remarkable decrease in blood pressure, even whether the blood pressure decrease was corrected for placebo. The second trial was the Bach's 24 trial, very interesting study carried out in patients with resistant hypertension and described by patients who don't achieve blood pressure control despite the treatment with 3 or more antihypertensive drugs of the different classes. The patient had been randomized to baxdrostat or placebo, and the primary endpoint for the reduction in systolic blood pressure over 24 hours to 8 BPM. Again, the baxdrostat was given in patient treated already with antihypertensive drug, and in particular, again, over 90% were treated with drug inhibiting the renin-angiotensin system, about 90% treated with calcium channel blocker, while in 48 of these patients, in the cocktail of treatment, there was a very effective beta blocker. These are the effects of baxdrostat treatment, 2 milligrams in the trial in terms of blood pressure control. These are the changes in systolic blood pressure, no differences in terms of blood pressure profile in the population at baseline, while after 12 weeks of treatment, there was again a remarkable reduction in blood pressure in the population while treated with baxdrostat. And what is important was that the drug was able to improve the dipping, nocturnal dipping of the drug without any change in the, let's say, circadian profile of blood pressure control over time. Looking at probably one of the most important variables, which is the percentage of patients achieving 24-hour blood pressure control according to the guideline, you will see that such a percentage was pretty high in patients treated with baxdrostat, while a very small population of patients achieved this result while treated with placebo. And the difference between the drugs and the placebo treatment was, as you can see, highly significant, thereby confirming the ability of baxdrostat to not only improve the blood pressure control in this population, but also allowing the achievement of the satisfactory blood pressure control expected according to the guidelines. What about the safety profile of this drug? Pretty good. I tried to put together the safety profile that emerged from both Bach's hypertension and Bach's 24 trial. You will see the overall rate of side effect was not different between patients treated with active drug and placebo. The only side effect that has some relevance is, of course, hyperkalemia, but we are talking about the treatment with a drug that inhibits aldosterone, which is giving on top of other drug having some impact on the renin-angiotensin system. The rate of hyperkalemia was slightly higher in patients treated with baxdrostat when compared to placebo, but the absolute number of patients who developed hyperkalemia was pretty small. And so I think that basically this could be something that we have to take care without being afraid of the changes in serum potassium while the patient is treated with baxdrostat. So, in conclusion, I think that when the treatment of hypertension has, of course, some need to be improved in terms of blood pressure control and prevention of cardiovascular disease, in particular in this very important population of patients with uncontrolled hypertension, where we are going to have a new way to approach the problem. The 3 points I would like to use for closing my presentation were, first of all, that we know that a large majority of hypertensive patients are not achieving the blood pressure goal despite the treatment with multiple drugs. And for these reasons, they are at very high risk of cardiovascular, renal disease, and mortality. So what we have to do now is try to act to reduce the burden of uncontrolled hypertension, which is one of the major tasks of the management of the prevention of cardiovascular disease worldwide. The second point is that now we have a drug, Baxdrostat, that targets one of the primary drivers of uncontrolled hypertension, which is aldosterone, and is able to inhibit aldosterone production, thereby reducing the probability of a negative impact of aldosterone in terms of blood pressure control, renal disease, and target organ damage. So we can target and address driver of uncontrolled hypertension, finally. Last but not least, the Baxdrostat has demonstrated to significantly reduce the blood pressure and to improve the blood pressure profile over 24 hours. And the level of achievement of controlled blood pressure with Baxdrostat is pretty higher than placebo, but is pretty higher to the one achieved with any other treatment which has been used before for the management of this very important patient population. So that could allow to improve significantly the patient outcome, which is exactly what we expect, what we need, and what we have to do to improve the burden of cardiovascular risk related to hypertension. So actually, that's all on my side. And before leaving, I would like to thank you with another beautiful view of one of the most important monuments in my city, which is called the Two Towers. And with the Two Towers, I thank you very much for your kind attention.
Thank you. Is Professor Borghi online?
Yes.
Is he online? Hi,
I'm here.
Good afternoon.
Good
Yes,
afternoon
thank
to
you
you,
for your
my
lecture.
friend.
We have the panel here, but due to shortage of time, we all heard your wonderful lecture. Sometime
you.
we'll have to hope to have you in person in Dubai. So
Of course, be
yes,
sure.
yes. And thank you so much for pre-recording your lectures. It went flawless. It was wonderfully well received here. We have a large audience and we'll have a loud clap for you. So let's give a big hand to Dr. Borghi.
Thank you very much.
Thank you.
It's an honor for me. It's a great honor, and I'm looking forward to join you in your beautiful country.
Thank you. Thank you. So we'll have the last lecture of the session.
Thank you so much, Professor Borghi, for this nice presentation. Is he still online?
Yeah, I'm here.
He's on. No, he's offline. He was, but
he's offline now. Okay.
So we proceed with the next.
No point to ask questions. Okay.
In the end, because we are already late. So Dr. Rajiv will present.
Shall we proceed? Okay. So you would like to...
Yeah, now we'll be coming to the last lecture of the session. And I would like to invite Dr. Rajiv Gupta, who will be talking on shots for the heart, why vaccines matter in cardiovascular disease. Dr. Rajiv Gupta, please.
Pointer. Oh, I got it. Good afternoon. Yes. Good afternoon. And today we shall, in this session, we shall discuss something beyond what we conventionally think about the atherosclerosis. Can I have the next slide, please? Oh, I got it. Thank you. So conventionally, we think atherosclerosis, when it comes to our mind, automatically the cholesterol comes in our mind, right? And we have enough drugs and enough awareness about the cholesterol therapy, not from now, but from last many decades. In fact, the work started from experimental animals, all consistently proven cholesterol means atherosclerosis, high cholesterol. Work of Ansel Keys, I remember, preventive cardiology, again, the same flow came. And somewhere in the line, we stopped thinking beyond cholesterol also to the extent. Of course, the other risk factor, hypertension, diabetes came up. Now I'm introducing you or not introducing you, drawing your attention to another axis, because atherosclerosis, you know, it's the elephant of mind. The way you look at it, you will find a difference. So looking from the atherosclerosis standpoint, the pathogenesis, drawing your attention from another axis, and that axis of inflammation, particularly subclinical inflammation, which like cholesterol goes for decades, unknown in the body, and nobody knows it, nobody checks for it. Even the checks which you have got like high sensitivity, so CRP, etc., they are not
targeting all the aspects of the inflammation, because there are patients, you will find subclinical inflammation, CRP negative, even high sensitivity, but interleukin 6 is high. Interleukin 6 is negative, but still interleukin 12 is high. So it's a big, again, a atherosclerosis when you call inflammation, it's a big elephant of the blind. We don't know what, but it is there. And therefore, the vaccination comes into the vogue. I tell you, this phenomenon of the linking the influenza virus with the cardiovascular events started from this region, Gulf, And there was a doctor, scientist from Harvard, from Boston. During the Iraq war, he was working in Iraq. And he was the first to point out that influenza virus is linked with the cardiovascular events. And that's how the umbrella started. I mean, the story started unfolding, and then we have the randomized trial. In 2007, it was presented. Immediately, American College of Cardiology and American Heart Association flashed it. This, is a preventive effect like that of statins, so please use it. And we were one of the earliest to raise awareness in the city of Align. So when we look at the vaccination as a new form of cardiovascular prevention, this is something which is, I want to highlight it in this session, that it's definitely true, it is there. We don't use it in our practice in conventional basis in the hospital or in the clinics, but definitely there's a link, it is there. There's enough now evidence, including evidence from the randomized controlled trial and including in the guidelines. So there's no hesitation now to recommend it. So this is how the story started with the influenza virus. And then we go for the other viral illnesses. We have seen in the COVID time, we have seen it with the pneumococcal other things and RSV virus and recently the herpes zoster. So I should share with you in the coming slides. So coming to the bottom line first, that guidelines, when you talk of the guidelines, which we respect, all of us respect, and we adhere, that you see that we have to follow the guidelines. It's a legal implication as well. And annual influenza vaccination for chronic coronary syndrome, acute coronary syndrome, and heart failure patient, and also for the stroke, is mandatory, is class 1. No doubt about it. I have mentioned the 2 guidelines, European, American, because we use it. But Canadian guideline, Australian guideline, other guideline also, consistently, they all put across class 1 indication. It's like primary PCI for a patient with a STEMI. Can anybody deny a patient of STEMI primary PCI? Oh, you will be sued in the court of law. Similar to the situation here. It's a class 1. If you don't do it, or if I don't prescribe it, well, I may be questioned why. And maybe the patient may look me from the legal standpoint as well. In fact, practically speaking, when I was writing in my hospital at the time of discharge of all acute coronary and heart failure patient, the nurses say, why you are giving vaccine? And then vaccine is not available, trying to procure it. Now trends are changing because my colleague also getting convinced, oh, it's a class 1 guidelines, so nobody can question me now in my practice. So this is how it is. I think the raising awareness starts from the way you practice. And of course, the pneumococcal vaccine and COVID-19 vaccine, we have all witnessed it. And that is known to protect a lot of cardiovascular illnesses, and a special pregnancy group like pregnant ladies, CST, heart transplant, no doubt about it. You do wonderful cardiac transplantation, but if you fail, if you don't follow the vaccination protocol for the transplant, because there are a number of the vaccination to be given in such patients. Now, influenza vaccine, of course, it reduces risk of infection by 60%, but MACE also by 30%, similar to the degree of statin therapy. In a statin, you have reduction of again 24, 25, 30%. Same thing with the one shot in a yearly, you will get a straight 30% reduction in the cardiovascular events with the influenza vaccine. A statin you have to take every day, but this no need to take it every day. Just once a flu shot and you are done, you have injected for 1 year. How useful it is, how good it is. And of course, when you use it following acute MI, that's a trial, a AMI trial in which there was a 40% reduction in the future cardiovascular events and MACE. And now another thing which I want to draw your attention, which people don't take, people don't talk, is about the herpes zoster vaccine. Now we have got herpes zoster vaccine, by GSK company, other thing. So this is the data which I got last year published, or maybe 1.5 years ago published in European Society of Cardiology Journal, and European Heart Journal, And that's a South Korean. I respect South Korea. Very meticulous system they are following. Very precise. And they have analyzed their data of 2.2 million people. Over 2.2 million people. Then people took the herpes zoster vaccine, both the doses, it's 2-dose vaccine, and the other group which did not take the vaccine. And then they did the propensity score matching because the risks for developing coronary events for the two people may not be the same. You have to match the age, gender, the diabetic status, etc., etc. So when they did the matching, they could find 1.2 million. So from 2.2 million, they came down to 1.2 million. And when they followed up, they found that there is a almost quarter, that means 25% reduction, almost all the cardiovascular endpoints. You talk of stroke, you talk of thrombotic events, you talk of MACE, you talk of stroke, arrhythmia, inflammatory heart disease, you talk of heart failure, consistently across the board you find it. And therefore, it's again an anti-atherosclerotic drug, almost like that of this statin. But this data is an observation. It's not a randomized trial. Now, companies trying to push a randomized trial because unless you have a randomized control trial, you can't move into the guidelines as a class 1 indication. So another viral infections which cause CVD production. Now, please note what we have got studies done that acute pneumonia has happened or acute severe viral illness has happened and risk persists only for 3 weeks or 4 weeks. That's what the study shows. But answer is no. The risk persists much, much longer. Over the years, risk persists. It's not only a period that you cover the hazard period of 1 to 3 months time and then you are done it. No, the risk is going to persist for years. I know the people in which COVID-19 time, they have got the COVID-19, mild COVID-19, they have got persistently elevated serum ferritin level, a marker of the inflammation that is lasting over 5 years, 7 years, still persisting. So the risk persists of subclinical inflammation. You may not feel it. Patient may not exhibit any sign and symptom, but it's like a silent killer, like cholesterol, as my predecessor speaker spoke. So this is what is happening. So these vaccines are playing an important role. You have herpes zoster vaccine, 2-dose vaccine. You take it now, and after 2 to 6 months, you can take the another shot. And it's a safe vaccine, excepting you will get a bit of the side effects, bit expensive, but it's worth attempting it. But it's still observational data. And I feel that people, particularly 50 now guideline, above 50 years of age. Earlier it was 65, then they reduced the age to 60 years. Now it is above 50 years of age, you can take it. And similarly, upcoming a vaccine is, which holds a great potential, is RSV, respiratory syncytial virus vaccine at the extremes of the age, children and above 65 years of age, that is shown to prevent, again in the observational data, prevent the cardiovascular events. And of course, COVID, we have big experience and, suffering that we know what is what. Now, the pneumococcal vaccine, again, it is in the guideline, class 1 pneumococcal vaccine in the elderly people above the age of 65 years. And please note, people are stuck with the age group, the 65 years, till you are not 65 years, don't take a pneumococcal vaccine. Answer is no. If you have any comorbidity like hypertension, diabetes, or CKD or COPD above the age of 18 years, that's the data, adults, you are indicated to take pneumococcal vaccine also. And you can get the booster after the 65 years, the lifetime vaccine single, and you can take booster after 65 years of age. And that's how, and it has proven to decrease not only invasive pneumococcal disease, but CVD also by 10% or so. So that's another interesting vaccine. So 3 vaccines, the guideline. Number 1, the influenza. Number 2, the COVID. And number 3 is this vaccine, pneumococcal vaccine. They are in the class 1. All 3 are the class 1 guideline for prevention of CVD, MACE, including heart failure, arrhythmia, and stroke. Now we come to the schedule. So these are the schedule which commonly follow. Influenza, you have to take it yearly. Before winter, of course, it comes in the month of October or September, you will get a new strain. And you can combine with any of the vaccines, pneumococcal, COVID-19 or COVID-19, you can take together, including respiratory syncytial virus, if you are above the 65 years of age or having the not only age, comorbidities like particularly lung issues, you can take it. Herpes zoster, of course, you can take it. We do not know how pluriannual means, maybe every 10 year, 8 year, yet to be defined. And DT polio also now coming up. And you have to take it every 10 years or something or whatever it is. So that's how the vaccines are protocol is there. Now, before the transplant, cardiac transplantation now coming up very fast, and many countries, particularly developed, are catching it up. And if you are in a transplant team, you don't transplant unless patient is vaccinated, because you know the immunosuppression is going to unfold a lot of infections, including virus and whatnot. And this is the protocol of this thing. You give them MMR also, even though they are adult, maybe 60 years, 55 years, you give them varicella, herpes, rotavirus, of course, the COVID, influenza, pneumococcal, tetanus, hepatitis A and B, and human papillomavirus. So this is the protocol in which transplant team goes, because you are going to create immunosuppression to these patients. Now, we have the existing gaps, because in the class 1, only 3 vaccines are there. Other vaccines will fall into this group once this existing knowledge gaps is bridged. And this is limited data of cardiovascular benefits of herpes zoster herpes. It's a observational data, as I said. We have to wait for a randomized controlled trial and need for studies for the mechanism of the vaccine-induced cardiovascular prevention. I think one mechanism, subclinical inflammation, is quite clear, which persists for years together, as I told you. And other vaccines may be there, maybe direct mechanism may also be there beyond the inflammation. And of course, implementation challenges, as I shared with you, difficult to convince my nurses and the staff that every patient needs it at the time of discharge. But if you insist, they have obligation to do it. And then, of course, serious adverse effect. We are very fortunate. We can adverse effect with ACE inhibitor, with all preventive therapies. But this is very, very safe, And 1 in 10,000 only serious adverse effect, and forget about it. And the vaccination is safe and effective and cost-effective pillar of cardiovascular prevention. Please try to implement it in your practice right from today if you go home. It's going to have a yield. The only thing you need, you set up and convince the patients and convince your team member that, look here, now it is in the class 1 guidelines. It's recommended for high-risk population, and further research, particularly at the implementation level, is going to be needs to be worked into. Well, this is a knowledge which is going to change, but wisdom will not change. I never end my talk without a wisdom point. If you need knowledge, keep adding something like you have come here to add. But if you need wisdom, then keep deleting some of the negativities from your mind. It comes from the meditation and the silence. With this, I thank you very much.
I think we should close the session, and I will felicitate. No time for discussion.
Discussions.
So thank you so much, chairpersons and speakers. Please be with us. We invite Dr. Rajiv Gupta. I think Amber will be doing a great job, and congratulations. Thank you so much. Dr. Amrish Agrawal. He was here. Dr. Amrish. Dr. Abdul Jabbar. Thank you. Wonderful. And then for our worthy chairpersons, Dr. Fakhruddin, thank you for being with us. Thank you for accepting. Thank you. And none other than Dr. Sachin. Thank you. Thank you. Straight away, we'll go for the next session without wasting any further time. So next session is chaired by Dr. P.K. Gupta, Dr. Murli Krishna, and Dr. Heman Lukras. I leave the dais upon them, and we'll try to catch up sometime. I know it's my apology that lectures are very closely packed, and I have to push hard, but we cannot help it. We have to maintain the time because we have online speakers at 5:30 and 6, and we cannot keep them waiting. They are from US. So please bear with us. Thank you. Who is the third? Dr. Heman, he's not here? Okay.
All right, so good afternoon, and we have got 2 lectures dedicated to heart failure. And the first one is biomarkers in heart failure from diagnosis to the precision risk stratification. And it would be delivered by Dr. Yogeshwari. She is a specialist cardiologist at Medcare Royal Hospital, Dubai. Dr. Yogeshwari, please.
Good evening, everyone. And at the outset, I'd like to thank Dr. Brajesh Mittal for this wonderful opportunity. And I would like to congratulate him for his 10th successful Shakeheart conference in here. So I'll move on to the topic proper. The last 2 decades have actually seen a remarkable advancement in the management of acute myocardial infarction. Now, where does it leave us? So it leads to survival. A lot more patients are surviving myocardial infarction, and coupled with an increase in aging, increase in diabetes, hypertension, CKD patients, clearly we see that a sizable proportion of these patients are left out with variable degrees of myocardial dysfunction, and that clearly adds to the heart failure epidemic. So what are we going to do about it? It's important for us than ever to be able to diagnose them early, and then to be able to institute the treatment, timely intervention, accurately risk stratify them, and timely intervention is very important for us so that we see better patient outcomes. And there comes a biomarkers wherein it plays an indispensable role in treating these patients in the current era. So what are we going to cover in this? I'm going to take you through the actual clinical burden of heart failure in the current situation. And then we have this traditional risk factors, which are predominantly congestion markers, and how we are going to move towards a multi-marker approach, wherein there are a lot of newer biomarkers that are coming in, which helps to identify the disease pathway rather than just identifying the phenotype alone. So also the diagnostic thresholds, of course, the cutoff levels of thresholds vary depending upon whether we are using them in the acute setting or in the chronic setting, and what are the confounding factors in them. And then how we are going to use them to risk stratify, and how we are going to use them to precisely manage these patients. So heart failure is pretty common, and diagnosis and risk stratification of heart failure remains pretty challenging because of its varied etiology and the absence of a definitive diagnostic test. Now, heart failure is a pandemic, everybody knows, and almost 64 million people are living with heart failure. And the symptoms and signs alone lack the accuracy to diagnose heart failure. And there comes the biomarkers, which are going to prove really helpful for us in diagnosing these patients. So 1 in 5 patients will have a lifetime risk of developing heart failure. And we all know that this is the number 1 cause of hospital admission stay in patients who are above 65 years of age. So what is actually a cardiac biomarker? Biomarker is a measurable indicator of a biological state or a pathophysiological process. And in heart failure, biomarkers translate invisible myocardial stress and injury into quantifiable and actionable numbers. So they serve all of these distinctive clinical roles, right from diagnosis, right from prognostication, help monitor the congestion therapy, help phenotype. And we all know that, heart failure is a complex interplay of various pathophysiological mechanisms. And there is neurohormonal activation, there is underlying inflammation, there is fibrosis, there's LV remodeling, all of it happens. And our body tries to excrete all of these natriuretic peptides, which acts as a counter-regulatory mechanism to contain the imbalance that happens because of the volume and the pressure overload. Now, eventually, once that gets triggered, then there is a signal transduction, and then there is cleavage of these inactive proteins. And then from pre-pro-BNP, it gets cleaved into the active BNP and the inactive N-terminal pro-BNP. The biomarkers concept actually began way before 1981, when we had this ANP and that was injected into rats, and then they found that the blood pressure is reduced, there was diuresis, but then eventually the ANP did have a very short half-life, and therefore it is very difficult to use it as a biomarker for us to risk stratify these patients or to diagnose these patients with heart failure. So the classification of biomarkers based on pathophysiological mechanisms actually make more sense to us, because it not just is going to help us identify the congestion or when the consequences actually happen. It is going to help us identify at a stage where the mechanisms drive the heart failure pathophysiology. So when it comes to so the markers are also specific to specific pathobiologic pathways, and thereby it helps us also precisely treat these patients depending upon the pathophysiology that is involved. So when you look at the traditional risk markers like BNP and NT-proBNP, they're pretty validated in landmark trials. And then they have a very cumulative evidence over the last 25 years in iconic landmark trials. And then we have clear-cut diagnostic cutoffs, age-adjusted thresholds, and prognostic significance and guideline-based recommendations. But the novel biomarkers, yes, they are extremely promising, still have not been able to find a concrete role in the guideline-based recommendations. But yes, when we are moving towards from single to a multi-marker strategy, it definitely is going to help us identify the etiology of the heart failure with much better understanding. So the two established pillars of heart failure assessment, we have the natriuretic peptides and the cardiac troponins. In natriuretic peptides, clearly we know that when there's a myocardial wall stress and stretch, these natriuretic peptides are getting released. And it's how many of you choose to request BNP and how many of you choose to request NT-proBNP? Which one is actually preferred? Especially in the current era wherein we are moving towards guideline-based guideline-derived medical therapy, NT-proBNP clearly has a far better prognostic value as compared to BNP, as BNP can be falsely elevated in patients who are on ARNI therapy, actually. Because ARNI is an neprilysin inhibitor, the sacubital component is an neprilysin inhibitor, and BNP gets excreted, one of the excreted mechanisms through neprilysin. So the BNP can be falsely elevated in patients who are on ARNI therapy. And in fact, if you give me an option where you want to use BNP or NT-proBNP, I'll always want to choose NT-proBNP over BNP. So cardiac troponins, if you look, they indicate cardiomyocyte injury, necrosis, and it's not very disease specific, but yes, heart failure patients do have a troponin elevation, and combined elevation of both BNP and troponins clearly has a far poorer prognosis and predicts adverse cardiovascular outcomes much than any single marker combined together. So, So there are also differences in the thresholds with which we have to interpret these BNP values. Now, if you look at it, in an acute setting, like for example, if a patient comes with acute shortness of breath to the emergency department, there's an acute rise in the ventricular wall stress, and we expect the natriuretic peptides to go much, much higher in acute settings as compared to the chronic settings. So we have to be mindful, and when a patient lands up in the emergency, we need to make sure that we use a test with a very high sensitivity so that we don't miss out these heart failure patients. Again, we do have scenarios wherein patients do present pretty early, for example, 30 minutes from the time of onset of acute pulmonary edema, then we still can have these natriuretic peptides coming as normal. So it's very important that you do not use these biomarkers to replace your clinical assessment, but it supplements your clinical assessment and thereby helps in managing these patients. So as mentioned, the natriuretic peptides do, when we assess them, they do have false positive, they do have false negative. And false positive in older age, there will be a diastolic dysfunction, there will be atrial dilatation. Atrial fibrillation patients inherently, they have atrial stretch, and then these natriuretic peptides are released. And therefore, when interpreting heart failure in patients who have AF, the threshold has to be almost 3 times from what we otherwise use to diagnose heart failure. So apart from this, in sepsis, critical illness, and renal dysfunction, as I did mention, because these NT-proBNP especially gets cleared through renal pathway. So in renal dysfunction, we expect these biomarkers to be already up. So the threshold for all of these patients, whether it be old age, renal dysfunction, atrial fibrillation, valvular structural heart disease is definitely different from other patients. So as I already mentioned, we also have a group wherein we have false negative risk, wherein the patients present much early, and then pericardial constriction patients who are on ANI therapy, who are obese. So all of these patients, we can expect a false negative values as well. So where do biomarkers actually sit in the heart failure workup? As I did mention, you have to have a clinical suspicion. That's the most important thing. They're never going to replace your clinical assessment. It's going to supplement actually. So in fact, I would ideally recommend in UAE, if it's there, it has to be requested by the GPs when a patient presents with shortness of breath, because it clearly helps to differentiate between a cardiac and pulmonary cause of dyspnea when the patient presents in the clinical setting. And so clearly the severity of heart failure, the higher the natriuretic peptides, the heart failure severity also matches with that. And okay, so a marker for ongoing myocardial injury, as I told you earlier, when you combine NT-proBNP along with troponin, the prediction or the prognostication is definitely far better as compared to using one of the markers alone. So beyond the traditional natriuretic peptides and troponin, moving on to the multi-marker panel, where are we right now? Now, among all of the newer biomarkers that I'm going to discuss, actually, the three promising ones are the SST2, the galectin-3, and the MR-Pro-ADM, adenomedallin. Now, all of these have a role in LV remodeling. We all know that inflammation fibrosis is a part of LV remodeling. And if you look at SST2, it is very much less affected by age or renal function. And unlike BNP, it's not a congestion marker alone. It reflects the biologic process that actually drives the heart failure. So it gives a clue to the understanding of the pathophysiologic mechanism and helps give specific treatments directed towards that. So galectin-3, again, is a marker of fibrosis and remodeling, and identifying patients at risk for adverse outcomes. It clearly helps. Supposing you're in confusion, when you have confounding risk factors, when using the traditional risk markers, you can definitely add galectin-3 or SST2. Currently, it has class 2 indication when you're in doubt or when the traditional risk markers are not being very helpful. So the fact that there is a variability across the heart failure phenotypes is one of the main reasons why we cannot clearly rely on a single biomarker alone. So that is why we need to move towards, and much of our evidence on these traditional biomarkers have stemmed from the heart failure patients with reduced ejection fraction, if you look at it. And in heart failure with preserved ejection fractions, all of us would have had patients wherein the NT-proBNP was probably normal. But again, in those patients, adding SST2 or galectin-3 can prove more useful in diagnosing heart failure patients as well. So turning numbers into clinical action, where are we? We use these to screen, prevent, diagnose, classify, risk stratify, guide, and monitor therapy. And does biomarker-guided therapy improve outcomes? The answer is yes and a no. Currently, whatever be it, we are not going to use biomarkers to optimize the therapy. We have to do that whether the biomarkers are elevated or not. But yes, it can be used to monitor your therapy. And as I told you, you have to adjust interpreting as per the patient's risk factors. So these are where the current major guidelines are recommended currently.
Try to wrap up in 30 seconds, please.
All right. Okay. So as I conclude, I will leave you with a glimpse of where we are heading towards today. The future is moving towards integrated multi-omic signatures that will help us define the heart failure phenotypes better. Maybe rather than just labeling patients as heart failure with reduced ejection fraction, we might classify based on dominant biological pathway affection. And you can combine the AI-based tools and algorithms, which can definitely strengthen your diagnosis and prognostication of heart failure patients. And yes, that is, of course, going to guide us towards a pathway-directed therapy. And with the use of a lot of remote monitoring devices, for example, if you can use these biomarkers at home, we can probably identify patients even before they actually end up decompensating. So thank you.
Yeah. Thanks, Dr. Yogeshri, for presenting the role of biomarkers in diagnosis, prognosis, and therapeutic decision-making in heart failure. Let's move on to the next topic. That's a dual SGLT1 and 2 inhibition with sotagliflozin, the next step in heart failure management Dr. Rupesh Singh, interventional cardiologist, Medcare Hospital, Sharjah. Dr. Rupesh.
Good afternoon. So today we are going to discuss about the dual SGLT2 inhibitor, sotagliflozin. As we know, the SGLT2 inhibitors has established their role in the basically heart failure, non-diabetic, diabetic, and CKD. But what next we can offer in this molecule may be offering something more. So we are coming to discuss all these things in the next slides. So as we know that the function of the SGLT2 basically on the kidneys, it is available on the like S1 and S2 segment of the proximal tubule, but SGLT1 basically available on the S3 segments. And here it prevents the reabsorption of sodiums. Along with it is represent on the heart as well as the small intestine. Mainly in the heart, SGLT1 receptors has the role in acute stress condition because it provides the glucose input that time in acute stress condition. But in the chronic heart failure, it was observed that they are overexpressed and the overall overexpression led to the detrimental effect. Like the catecholamine receptor in the heart failure, in acute phase they help, but in the longer phase they have led a detrimental effect. In the small intestine, again, it basically prevents the absorption of the glucose and galactose molecules, and that prevent the calorie, you can say, deficit it causes. So as you can see in proximal tubule, in the ST3 segment, it is present and it works same way as SGLT2 inhibitors works. In the intestine, it basically prevent the glucose and galactose absorption, and in the heart, basically it works for the sodium and this one glucose input. But in long term, it is detrimental. That's why it is in the, if you inhibit it, it has protective effect. The same slide, how it works, we can see in the, we can see in this one, how it works in intestine and in the proximal tubule of the kidneys. For SGLT2, all we know that it basically in kidney reduces the preload and afterload, decreases the intestinal fluid, plasma volume, and vascular resistance, improve the endothelial function, improve myocardial energetics, decrease in the reliance on fatty acid, increase in ketone formation, cardiac nitrogen hydrogen in epithelium inhibitors, and cardiac remodeling also helps, and has had clinical benefit in form of BP reduction and improved cardiac contractility. Now coming to the coming generation of SGLT2, when we see the selectivity of that, so empagliflozin has almost 250,000 having more effective on the SGLT2. DAPA is almost 1,200 more selectivity towards the SGLT2. Canagliflozin almost 250. But when the sotagliflozin is there, it is you can say 20 times only SGLT2, and it is more towards the SGLT1 receptor inhibitor. Coming to two trials, which is the most, you can say, conducted for this molecule. One was the Solaris trial. It is basically done on the heart failure patient, diabetes and heart failure patient who are admitted due to the acute heart failure. And before discharge, this medication was given. And the primary efficacy was total CV death, heart failure hospitalization, and urgent heart failure visits. If you see the relative hazard ratio was 0.67, and there was attributable ARR was 25 events in per 100 patient years in comparison to placebo. If we see the effect across the all subgroup, whether the EF was more than 50 or less than 50, it is equally effective. Even in the kidney problem, whether the eGFR was less than 60 or more than 60, it is equally effective. Second trial was the SCORE trial. Basically, this trial was conducted in patients with diabetes and CKD, but due to the abrupt closure of this trial due to funding, and that time COVID was going on, the primary endpoint was included later on the not kidney events, but the primary event of the cardiovascular events. And this patient, as I told you, the inclusion criteria was diabetes and CKD. That means eGFR between 25 to 60. Whether they have microalbuminuria or not microalbuminuria, this they are included in this trial. And again, the primary efficacy was here in this trial was also basically total CV deaths, heart failure hospitalization, and urgent heart failure visit. Again, the hazard ratio was at 0.74 only, and AR was 1.9 events per 100 patient years. Later on, the data was extrapolated for the CKD benefit, and it was almost 34 reduction in the CKD group also was there. But initially, when trial was abruptly stopped due to COVID and this outcome was there for the cardiovascular event in patient with having diabetes and CKD. Now coming to the meta-analysis of sotagliflozin. So why this meta-analysis was done? Because as we know that heart failure burden almost 64 million population affected worldwide, significant burden on the healthcare system, need for novel therapeutic approaches because already we have SGLT inhibitors which already emerged as a pivotal therapy, and SGLT2/1 inhibition offers additional CV benefits via GLP elevation, and dual inhibition of SGLT1 and 2 may offer superior diuretics and natriuretic effects. So that's why this meta-analysis was conducted. And as we know, the sotagliflozin is having first in dual SGLT2 and SGLT2 inhibitors. FDA approved already for the heart failure, both in preserve and reduced ejection fraction. It inhibits SGLT1 in the intestine, leading to decrease in glucose absorption, inhibit SGLT2 in kidney, and that way increase more urinary glucose excretion. And both in the trial which I have discussed already established decrease in the CV deaths, heart failure, hospitalization. So this meta-analysis was done by these different criterias and different research. This one was done. And this meta-analysis almost included 15,000 patients, and median follow-up was roughly 13 months. But majority of this RCT was with the placebo arms. There was no study which is compared it then with the alone SGLT2. Only in one trial GLIM was included, but otherwise all are majority placebo arm was there. And dose of use was either 200 or 400 milligram per day. So primary outcome of composite heart failure was relative risk was 0.66 only, with the confidence interval just 0.64 to 0.69 only, almost 34% relative risk reduction. Net number to treat was just 20, 52 fewer events per heart failure in the over 1,000 patient, and the level of evidence was moderate. And when we did the sub-analysis, their CV death hazard ratio was 0.9, MI was roughly 0.85, stroke roughly 0.74, and the MACE was 0.72, and composite heart failure was the 0.65. So majority benefit came through the no doubt decrease in composite heart failure. And in this meta-analysis, the systolic blood pressure was reduced by 2.38 millimeter of mercury, and body weight was 1.17 kg. And net number for the MACE was 34 only. So what was the probable mechanism of cardiovascular benefit? On the renal domain, you can say the increase in the urinary glucose excretion, osmotic diuresis leading to the decrease in plasma volume, intravascular filling pressure decrease in preload and afterload, and obviously decrease in the systolic blood pressure. On the GI tract, it was basically decrease in glucose and galactose absorption, increase in the GLP-1 secretion, increase in peptide Y, and weight loss and caloric wasting, and decrease in postprandial hyperglycemia. And direct cardiac effect was that decrease in reactive oxygen species, decrease in matrix metalloprotease, decrease in toxic calcium accumulation, decrease in myocardial fibrosis, and improve in the cardiac energy metabolism. So what were the side effects? Side effect was more or less similar to the SGLT2, having increase in the genital mycotic infection. Relative risk was around 2.83. Genital infection, relative risk was 3 roughly. Diarrhea, because it is basically works as a, you can say, decrease in the glucose absorption, leading to more osmotic diarrhea. Volume depletion, some patient develop hypotension and this thing. Gastrointestinal side effect in form of diarrhea and these things. And serious side effect was more or less than in the placebo arm. So there were no serious side effect, but these side effects were there, more or less matching with the SGLT2 inhibitors. Only the GI side effect was more with this molecule. What the limitation of this trial was there, this meta-analysis, basically this risk of bias was only 50%. And this all data was collected through the English language. So obviously other trial we not included in this meta-analysis. There was no head-to-head trial between the SGLT1 combined inhibitor and SGLT2 inhibitors, because all this trial was included as a placebo arm and sample size was small. So what conclusion we can draw? So sotagliflozin significantly reduces composite heart failure risk by 34%. MACE was reduced by 27%. Significant reduction in the systolic blood pressure in tune of 2.38 millimeter of mercury and body weight in the tune of 1.2 kg. And HbA1c reduction in the tune of 0.45%. No dose-dependent effect was identified between the 200 milligram and 400 milligram doses. And sotagliflozin is effective as and potential superior to current SGLT2 inhibitors, but still head-to-head RCT are warranted.
Thanks, Dr. Rupesh, for finishing before time. And you have given a very good review of SGLT1 and 2 inhibition across the spectrum of the heart failure. And we will take question at the end of the session. And Dr. Murali Krishna will introduce the next.
Good evening, everybody. The next speaker is Dr. Yasmin Ajaz, who is the consultant endocrinologist at Medcare Specialty Hospital in Sharjah. And he'll be talking about a revolution in diabetes management from prevention to remission.
Good afternoon. And if you talk a few decades back, we never talked about prevention. We never talked about remission. We just talked about how can we prevent complications. With the newer drugs, things have changed. So my topic today is revolution in diabetes management from prevention to remission. This is why we are here. If you see, this is the idea of data. Around 589 million people with diabetes, and within few years will be going up 45%. And if you see the MENA region, will be up by 92%. So that is why we have to do something. And we talk about the exchequer is about more than $1 trillion. So can we prevent diabetes? If so, when? Shall it start early, much before pre-diabetes? Definitely, yes. It all starts with insulin resistance and also visceral obesity, which comes before the hen or the chicken. Simultaneously, they come, and they are the one which are the harbingers of type 2 diabetes. And we should try to do as early as possible, even starting in childhood. Obesity and diabetes goes hand in hand. You know that patients who have diabetes, 80 to 90% are obese. And if you're obese, the chances of getting diabetes are 7 times more than the general population. And with increase in diabetes, the class of obesity, it can go up to 40%. This data is clear from the ADA. If you are able to decrease your weight by 5 to 10%, you definitely are going to prevent diabetes. And if you lose around 10 to 15% of your body weight, your diabetes might go into remission, which is defined as HbA1c of less than 6.5%, at least for 3 months without taking any medications. That is why treating diabetes is not all about sugar, sugar, and sugar. It's not glucocentric anymore. It's centered around the cardiorenal metabolic syndrome. Let's talk about prevention of diabetes. Started as early as 2002 with the diabetes prevention program, where they took around 3,000 participants with pre-diabetes and put them on intensive lifestyle modification, metformin and placebo. But they found that those patients who were on lifestyle modification, they did very good with the 58% relative risk reduction in diabetes as compared to metformin. And this is not only that, when they did a 15 years follow-up of these patients, they still found that lifestyle modification is a winner, all hands up. So this is the best drug for preventing diabetes. You don't have to run like crazy. Just lose 7 to 10% of your body weight. Things will be much, much better. Talking about remission, a wonderful detail by direct trial, where they took around 306 patients and they did they decreased their calories to the tune of around 500 to 800 calories for 3 to 5 months. And these patients were type 2 diabetes with the duration less than 6 years. what they found amazing, that 46% of these patients, they were in remission at 1 year, and after 3 to 5 months, their food was reintroduced. And by 2 years, still 36% people were in remission. On top of that, you get some plus points in terms of weight loss, A1C, systolic blood pressure decrease. So the question here is just weight loss. So there's a paradigm shift now. We are no longer managing diabetes. We are rewriting its future. Very important. Old model was glucocentric. New model, you go for prevention, you go for precision therapeutics, you go for technology integration, you go for weight-centric care, and definitely you go for remission and disease modification. All started with the Gila monster. It gave the saliva from the Gila monster, which was the Exidin-4, and subsequently things started moving from exidinide to tirzepatide, and now with retatrutide. Do we have data of reversal of diabetes with these drugs? Definitely. We have a wealth of data from SURMOUNT-1, where the patients were non-diabetic, they were overweight, they were pre-diabetic. A whooping 94% of patients went into normal glycemia, HbA1c less than 5.7, and go for the SELECT trial with semaglutide, again, a whooping 73%. So yes, you can take them back to normal glycemia if you lose weight. It's not only that. In diabetics, when you use these drugs, you get a wonderful reduction in HbA1c to the tune of around 1.5 to 2.6%. You get weight reduction of around 10 to 15% with SEMA and 20 to 25% with tirzepatide. You have a major adverse cardiovascular event reduction by 20% by semaglutide in SELECT trial, and by tirzepatide, it was non-inferior to liraglutide, which has data by the REWIND trial. On top of that, you have the flow data for the CKD and the renal outcome. When you talk about weight loss, see how tirzepatide scores to the tune of around 22% as compared to semaglutide and also the waist circumference. The TRUMPH-1 data is available with the retatrutide. It's almost approaching bariatric surgery. You're getting a loss of around 28%. And what is wonderful in this data, almost 45% of patients lost around more than 30 kgs. So imagine these overweight patients losing 45%, losing 30 kgs. Technically, everybody will go into normal glycemia. This is very important. How does these precision technologies help in getting remission? You can clearly see you have newer data, newer things. You can monitor your numbers. You can use AI integration. You can use the technology and you can hit the button. And it has been seen with these technologies, you can get around 1.5 to 2% HbA1c reduction. And definitely the remission is possible in about 30 to 40% using these technologies. This is the CGMS system, which is a policeman. Whenever you're using it, definitely you have a lot of patients who know what to eat, what not to eat, and go into normal glycemia. This is the slide which I made. It took me almost 1.5 days to make the slide. But this is a patient. If I'm treating this patient in 2010, following the standard of care, and now he presents in 2026, I would have probably is a new-onset diabetic, 55-year-old, HbA1c 9.5, high risk, EGFR and UACR is 190 ml. You see he's on basal insulin, sulfonylurea, metformin, statin, and ACE. And if I would have put one more, I would have put in a carbos and giving him gas all around the town. Now, what do I expect outcomes in the next 1 decade to increase, to make sure that things will not be good? Is that HbA1c will be out of control. He will gain weight. You will have hypoglycemia. The risk will increase. But what happens if we treat him now with the newer medicines? He will be on GLP-1 receptor agonist. He will be on dual, probably tirzepatide, probably SGLT2 inhibitor, high-intensity statin. And with this early combination therapy, with this lifestyle change, we might get him into remission, which is HbA1c less than 6.5 for more than 3 months. The goal has evolved now from glucose control to protecting organs and promoting healthy life. So the 2026 approach, yes, the remission is possible. Life expectancy is improved. Quality of life is better. Need of dialysis is unlikely. Kidney failure is unlikely. And there's high likelihood that the patient will not have major cardiovascular events. So this is what we have to treat now. We have to go in this care model. So this is my summarizing slide. So our goal has evolved from lowering glucose to transforming lives and changing the future of cardiometabolic health from prevention, stop it before it starts, go on diet, go on exercise, take metformin, take GLP-1 receptor agonists. And we have all the revolution has been driven by these powerful medicines, by technology, by AI. And these goals are with us with newer devices, lifestyle modification. So is diabetes remission possible? Yes, it is definitely possible with early diagnosis, intensive lifestyle intervention, effective medication, and sustained support. Up to 30% of patients can achieve remission if we follow these guidelines. This is my last slide. The future of diabetes is not merely survival, it's restoration, precision, and hope. Thank you.
Thank you, Dr. Azad. It was a really concise and very up to the point presentation, and the message you conveyed is, yes, I think that's the future for diabetes management. We'll take up questions after the next talk.
Thank you.
Now for the last talk, I request Dr. Mrudula Dakar she's the interventional cardiologist from Medcare Hospital in Dubai. And she'll be talking about rethinking risk, novel biomarkers and predictors in cardiovascular disease.
Thank you, Dr. Murli. Good afternoon, everybody. And congratulations, Dr. Mittal, as always, for bringing to the fore all the, you cover almost all the topics. So I see today it's all about prevention, and that's a good thing to know that we are moving backwards in the population to start from where the disease has not started yet. So my topic today is redefining the risk by basically new markers, so novel biomarkers to predict cardiovascular disease. So basically, we have been so far using the old risk predictive models, and the lipid levels is where the atherosclerosis begins. The lipids is the starting point. So lipid levels alone, they do not fully reflect the atherosclerosis status, thus necessitating extensive research on the CV markers. Inflammation underneath, oxidative stress, plaque instability, cardiac remodeling, and fibrosis, they play an important role in pathogenesis. And I think as already spoken by Dr. Pradeep Gupta and Dr. Yogeshwari also, we have talked about the biomarkers. So a little bit more on that. So decoding the hidden risk by the precision biomarkers. They're emerging as critical tools to bridge the gaps in cardiovascular risk prediction. And beyond the traditional risk scores, they improve early detection of subclinical disease. They enhance the diagnostic precision by predicting, again, the stress, inflammation, cardiac injury before actually the overt symptoms arrive. And they identify the residual risk beyond the traditional metrics. They facilitate the personalized preventive care. So guide targeted therapy, because if we are diagnosing the patients much before the overt symptoms have become, or the traditional risk factors have somehow hidden the underneath disease process, we are able to prevent at an earlier stage and guide towards targeted therapy. They excel at early myocardial injury detection and dynamic risk evolution in heart failure. So almost for more than 3 decades, risk prediction has been used for primary prevention. And contemporary cardiovascular risk assessment relies on multivariable risk models, which integrate established cardiovascular risk factors like diabetes, hypertension, high lipids, smoking, non-smoker, family history, etc. They have evolved over time from Framingham risk model to pooled cohort equations and now to PREVENT, which is the latest risk stratification model that we intend to use in future. The recent scientific genomics, proteomics, metabolomics, and methodologic with artificial intelligence, these advances have led to a proliferation of novel models. So the era of relying exclusively on standard multivariable risk models is ending. By systematically integrating these new methods, including the epigenetic biomarkers, we are transitioning from observing 50% of late-stage events to forecasting the entirety of subclinical trajectories. And so finally, we feel that we are possessing the tools to foresee the future harm. These markers have potential of newer approaches to improve the risk prediction, but there is definitely a need for rigorous evaluation and assessment of their performance. That is their accuracy, their precision, incremental performance when added to current risk calculators, and clinical utility. That is actionability, scalability, and generalizability before adoption in clinical practice. Because they're very variable, their reproducibility is really very important. An additional consideration is cost value. How much we can use these various biomarkers in general population, what will be the cost effectiveness, time will tell. Evaluating current and emerging risk prediction strategies and ultimately improving the cardiovascular disease prevention in diverse population. They intend to do the deeper prevention. So this is the precision medicine toolbox. As you can see, different markers, they pertain to different pathways. So in the first column, the ApoB, lipoproteinase, ceramides, they pertain to the lipid and metabolism pathway. In the second column, the high sensitivity CRP, these are just few of them I'm speaking. There are more to the list. So the glycoprotein A, galectin-3, they are pertaining to inflammation and fibrosis, especially in the heart failures. Then the high sensitivity troponin, NT-proBNP, soluble tumor 2 marker, then the H-type fatty acid binding protein, they pertain to stress and injury, target subclinical myocardial strain. And the genetic and epigenetic markers, they are really a very interesting arm of this whole armamentarium. And I don't have enough knowledge to speak on this, but very interestingly, the microRNAs we are targeting microRNAs to be able to study at the RNA level. Inclisiran is the best example, which targets and inhibits the production for a long period. So similar, we are targeting certain medicines targeting for different diseases. So the DNA methylation, again, the study of methylation of DNA, whether it is gene deletion or addition, in order to change the landscape of the genetics of a generation. So very interesting topic. So here, as you can see, Professor Ramazani, as far back as in 1700, quoted that prevention is better than cure. Even today, we do see with whatever we have, there is a clinical blind spot. We can see 50% of the people which are not seen to have disease, but we can still miss them because they may have subclinical disease progression. So detecting the subclinical cardiac stress and injury by these markers, for example, by high sensitivity troponin and fatty acid binding protein, we are mostly using it for acute MI diagnosis. Mostly, of course, we all know that they are false positives. But now these assays are also being done in normal and healthy population to quantitatively estimate what we today consider normal. Even if they're subnormal, they have set up a limit, an intermediate limit, below which they are suggesting that this can be a beginning of a disease. So high sensitivity assays now detect baseline subclinical myocardial injury and necrosis in entirely asymptomatic population. And in case of stress and remodeling, the NT-proBNP signals acute myocardial wall stretch. ST2 and galectin serve as critical markers for ongoing cardiac and fibrosis, inflammation, and ventricular remodeling in an early stage heart failure. So the common denominator, as we all know, in a coronary artery disease is a destabilized vulnerable plaque, which causes acute MI. And we want to work at the level of prevention. So before it has gone, progressed, and we are at the level of acute MI, we want to study the inflammatory markers and see whether there is some uprising already happening in the intimal layer. So this is just to show that the atherosclerosis is propagated by inflammation initiated by lipids, and then the clots finally occluding the vessel and creating the whole the occlusion of the vessel. So we have to look at this diagnostic gap in the last box, where traditional risk factors only measure the crude presence of phase 1 materials. They fail entirely to quantify aggressive inflammatory propagation occurring beneath the surface. I think I'll go past this. I won't have time for this. These are the basic calculators. I can just read from here, like this is an example of a patient being studied by ASCVD, our 10-year pool calculator, where the age of the patient is 40, total cholesterol 150, HDL is 60, systolic blood pressure is 168. He's on blood pressure and diabetes medication, and he's a non-smoker. The calculated 10-year risk of cardiovascular disease is 1.7%. But in this calculator, we don't have the family history mentioned at all. Another FRS calculator, the Canadian risk calculator, this considers family history of premature cardiovascular disease also as one of the criteria. So if we take the same patient, the criteria, the risk increases to 15.8. So he becomes a low risk to an intermediate risk patient. So the new calculator, which is PREVENT, this also accommodates for not just a 10-year calculation, but for a longer 10 to 30-year calculation, because anybody who is today a low risk and he's a smoker, he will add up to his risk over a period of next 10, 20, 30 years. So he would not, if we consider a 30-year, if we calculate and if we predict his risk over a 30-year period, he will fall into an intermediate risk in today's date, even though he's in a low risk, because he's probably only smoking and he's not into any other, he doesn't have any other risk factor. So in such a patient, I will just for a brief discussion, come back to this patient. He's a 52-year-old male. He has no ischemic symptoms, does moderate physical activity. He's a non-smoker with no diabetes or hypertension. He has a family history of premature CAD with MI, having had MI in father, brother, and an uncle before the age of 50. His BMI is 29.2, chest X-ray normal, ECG just shows sinus bradycardia. TMT was negative at 11.3 meds, and labs showed a LDL of 140, triglyceride of 92, HDL 51, and LP of 64. Now, such a patient, if we want to think next, what should we do? Is it a calcium artery scoring? Is it a is the intima media thickness? And there is new guideline of calculating the ceramide score also. So as per this, I would like to refer to this particular study, ceramide 2 essay, which was published in 2024. And they talked about importance of ceramide score, where these are basically phospholipids present in all the cell membranes, and they increase in certain situations. So ceramide score has based, there is a calculator based on the ceramide score, and it identifies hidden risk in individuals not known to have coronary artery disease or elevated levels already. So
30 seconds.
So I would just go past these three things like intima media thickness, coronary calcium scoring, ceramide scores. These are important for assessing the risk. And lipoprotein, I just want to talk 2 words on them, on lipoprotein A and ApoB, that it has emerged as an important genetically determined independent risk factor. And new treatments are already on the way. So I would just show you a slide where we should screen them, especially patients with familial hyperlipidemia, those who have a personal or family history of premature CAD, those with intermediate risk by the ASCVD risk calculator, those who have evidence of any other vascular disease, atherosclerotic disease, no response to statin therapy, or progressive atherosclerosis despite controlling all the risk factors, first-degree relatives with elevated LPA. And the important thing is universal. One guideline has also included it as a universal screening in all the patients. So these are the novel therapies underway. Some of them are in phase 3 trial, pelacarsen, olpasiran. So they are quoting even up to 90% of LPA reduction. Today we are talking of inclisiran, Repatha, evolocumab, etc., which can reduce it up to 20-25%. But these quote will be...
It's more than 2 minutes now.
Okay, so fine, that's it. The genetic record is These are all under investigation. And so the future is all about multiomics and machine learning, and we will learn a lot with AI, inclusion of AI, biomarkers,
Yeah.
multi-marker strategy.
I think all the speakers have done a wonderful job, and we have got just 2 to 3 minutes for any
Thank you.
burning questions.
Thank you so much.
So, any question from the audience? If no, I will just summarize in 2 lines. In the first speaker, every patient of stage A heart failure, yearly NT-proBNP should be done to detect the heart failure. So we can arrest progression from stage A to B, C, and onwards. So that's a one message. The last one, of course, about the biomarkers. And again here, the early detection and prevention is the key. The heart failure SGLT2 inhibitors are class 1A recommendation all across the spectrum of ejection fraction. So I think, and of course, diabetes, it was a wonderful talk. And how we can achieve the diabetes remission was wonderfully highlighted by the speaker. Thank all again.
Thank you so much for doing a great job, all the speakers, and also obviously the worthy moderators and chairs. We will just quickly have some felicitation. So I'll call upon Dr. Yogeshwari. The last. Yes. So you call Dr. Yasmin Ajaz. Dr. Yasmin. Thank you. We'll call Dr. Mizla, please. Dr. Murli is a great friend. Thank you for joining. Now I call Dr. Rupesh, and he has his folder. So there is a folder for Dr. Rupesh. So in the felicitation session, inaugural session, this year we have started to give some award of fellowship. So you are one of the chosen ones out of a dozen, and this trend will continue year by year. Not that others are not worthy, but just to keep a good number. So this is. Please give a round of applause. Yes, Doctor. Oh, Dr. Bish.
No problem.
No problem. Yeah. So Dr. Amrish is the speaker in the last session. And thank you. Final people. Thank you. Thank you. Thank you, everybody. As the evening progresses, we have the second last session. And for that, I will call the chairpersons, Dr. Sundar and Dr. Rupesh. Dr. Ghazi and Dr. Tamkin have apologized. They are not available. So the dice is with you, and there are 4 speakers. And as usual, we'll try to maintain the timings, Dr. Sundar. So Dr. Sundar and Dr. Rupesh, please come over. Thank you, and take over.
Good evening. First presentation, it will be by Dr. Abhay Nigam. He will be speaking on the peripheral artery disease, an unrecognized driver of cardiovascular morbidity and mortality. Over to you, sir.
How to forward? It is forward. This is back. And this is a pointer. Thank you, Dr. Brajesh Mittal, for inviting me to this prestigious conference. I will be discussing today peripheral arterial disease, an under-recognized driver of cardiovascular morbidity and mortality. This is my disclosure. And yeah. Looking at the epidemiology, globally, 236 million people suffer from the peripheral arterial disease. The important point to note is that PAD is significantly underdiagnosed. Only a minority of the patients present with classic intermittent claudication. Screening high-risk population is critical for early detection and prevention of limb loss and cardiovascular events. Now, risk factors for peripheral arterial disease, if you look, tobacco, smoking, and diabetes mellitus, these are the strongest risk factors. Hypertension, dyslipidemia, and chronic kidney disease are other risk factors. And age and family history are non-modifiable risk factors. There are also some non-traditional risk factors like overweight, sedentary lifestyle, sleep disorders, stressful lifestyle, etc. So they should also be kept in the mind. If you look at the prevalence of PAD in US, almost 8 to 12 million people are suffering. And this is a very eye-opening data because this figure is almost double as compared to stroke, yet we do not talk much about the PAD. By 250, almost prevalence is expected to reach 19 million. The patients with PAD carry a substantially elevated risk of MI, stroke, and cardiovascular death. And almost 50% of the PAD patients have concomitant coronary artery disease and 30% have concurrent cerebrovascular disease. So it is very important that all these patients should be screened for cardiovascular risk with including ECG and lipid panel. Aggressive risk reduction measures should be taken, which should include statin, ACE inhibitors, diabetes, and blood pressure control as per guidelines and multidisciplinary care. ACC and HA guideline recommendation class 1 that patients with PAD should receive intensive ASCVD reduction therapy equivalent to that recommended for high-risk CAD patients. The Partners program evaluated the prevalence of PAD at the at-risk patient, and they checked 7,000 patients almost in physician office. Inclusion criteria was either age above 70 years or 50 to 69 years with a history of smoking and or diabetes. Almost 1/3 of the patients were surprisingly diagnosed with the PAD. Now, looking at the typical versus atypical symptoms, traditional typical symptoms of intermittent claudication in calf muscles is only in 1/3 patients. 2/3 patients of the PAD have often atypical symptoms, which has pain in the other areas other than the calves, and it may not stop the patient from walking, and it may not resolve with some rest. So 2/3 patients have atypical symptoms. Impact of survival, if you look at, the severe symptomatic large vessel PAD patients have almost 25% survival only as compared to normal control subjects. Cardiovascular events, 6 times greater risk
of death from CVD, including MI and stroke in the patients of PAD. Prognostic importance of PAD in undergoing coronary revascularization, 5-year mortality risk in asymptomatic PAD patients who undergo revascularization is much, much higher as compared to the patients who do not have peripheral arterial disease. Also, there is increased incidence of peri-procedural complications in PAD, both when that they undergo CABG or angioplasty. These are the guideline recommendations, and all the patients who are planning to undergo CABG or CAD patients or an heart failure patient, they should be screened by ankle brachial index by Doppler for PAD. Now, diagnosing of PAD is extremely clinical importance for two reasons. First is due to identify a patient of high risk who has subsequent risk of MI or stroke, regardless whether symptoms of PAD are present or not. And second is to elicit and treat symptoms of PAD which may be associated with functional disability and the limb loss. How it is diagnosed and evaluated? The clinical evaluation is, of course, with the history taking of claudication and examining peripheral pulses. And the most important test is the ankle brachial index by the Doppler. And we also can employ treadmill test, duplex sonography, MRA, and contrast angiography in suitable cases. We know 1% risk reduction in the A1C leads to significant risk reduction in the diabetic complication, but you look at it, maximum benefit is in the risk of amputation, and in PAD, 43% risk reduction, which is far more higher as compared to other complications. Now, how do we do the ankle brachial index? The first and important thing is to let the patient take, it's a simple OPD non-invasive procedure, which can be easily done by any clinician. Patient should take a rest in the supine position for at least 10 minutes and check the systolic blood pressure in both arms and both ankles. Use a handheld Doppler, usually 8 to 10 megahertz, and only higher arm pressure is used. At the ankle, we check the pressure, only systolic pressure in dorsalis pedis and posterior tibial. Here also at each ankle, only the higher pressure is used. Divide the lower limb pressure by the arm pressure. If the value is more than 1.4, then it is because of calcification. These patients need further evaluation by toe brachial index or some other technique. If it is 1 to 1.4, then only it is considered normal, and then 0.9 to 1 is borderline, and especially if it goes less than 0.5, it is severe and critical limb ischemia. These patients should be referred to a vascular surgeon for intervention and further evaluation. Now, in 2024 ESC guidelines, two important things have come up. One is the goal of the systolic blood pressure in these patients of PAD, especially if they have hypertension, is 120 to 129. Previously, the recommendation was less than 140/90. And also, the LDL reduction goal is now less than 55, which various previous speakers have also highlighted, and a 50% reduction from baseline. This is again a class 1 level A recommendation. The previous goal was less than 70. Coming to management of the this thing, smoking cessation, most difficult and most important. Supervised exercise therapy, simply doing non-supervised exercise therapy has much less beneficial effect. The supervised exercise therapy has got excellent results. Diabetes, diet control, weight management, blood pressure and dyslipidemia control as per the guidelines must be undertaken. Antiplatelet therapy, aspirin or clopidogrel can be used, but clopidogrel is preferred over aspirin based on the Capri trial results. Statin therapy already has been discussed and must be used high intensity statin therapy only. A combination of rivaroxaban and aspirin is quite useful in these patients, but this cannot be employed in patients who have high risk of hemorrhage. Cilostazol is the only medicine which is directly improves the walking distance in this patient, but any type of heart failure is absolute contraindication for use of cilostazol. SGLT2 inhibitors has got great role. SOUL and STRIDE trials were done with the semaglutides oral and injectable version, and both showed a very good and significant improvement in the walking distance and outcome in cardiovascular events. Key takeaways are that diagnose early, reduce cardiovascular risk, relieve symptoms, and prevent the limb loss. But do not miss ankle breakage index. If it is more than 1.4, it is non-compressible. Do not diagnose it as a normal. Use toe brachial index. 70% of PAD patients are asymptomatic. This must be kept in the mind. So screen high-risk populations proactively. Cilostazol is contraindicated in all grades of heart failure. And PAD is not a local limb problem. Treat the whole patient as the high ASCVD risk case. And these are the references. And thank you very much. I hope I finished in time.
That was a very good, concise presentation, sir. On time. So we'll keep the questions to the end. Yeah, so just wait. We'll keep the questions to the end. The next presentation will be Dr. Virendra Kumar Mishra. This will be about the micro and nanoparticles, unrecognized risk factor for cardiovascular disease.
So good evening or good afternoon, whatever. So this is a very interesting part after this. Nano and microplastic pollution and cardiovascular risk. The most of the study is done in last, you can say, oh, this is showing 11 already? Clock? Not 15. So anyhow, so the cardiovascular risk is one of the things which these nanoplastic has shown. I will just go because it's not, oh, sorry. Okay, yeah. Okay. So what we are going to cover in next 10-15 minutes is what are these microplastics and what are the source and what is the evidence of these microplastic, how we are going to calculate this. In this one bottle, can anyone imagine is there are nanoplastic, microplastic? If I say there are 150,000 particles are there in this bottle. There is a technique which was not available before, only available in last, you can say, probably 2-3 years back. Majority publication has come in last 1 year or 2 years time. What is the evidence that these microplastic in our body and what we can do for them to diagnose? So microplastic, anything of 5 millimeter up to 1 micrometer is microplastic. And when they are less than 1 micrometer up to 1 nanometer is nanoplastic. And there is a global burden of this. We know 400 million tons of per year these microplastic is coming into the global or by which is going to increase by 2050. There is a plastic used in everywhere, in everything because of the low cost, versatility, widespread use in packaging, in healthcare, and we cannot avoid. So what is the primary risk and primary source? What is secondary source? Particles. So whenever they are manufactured as a very small particle like industrial resin pellets, fibers, textile, the quilt you are using, the pillow you are using, they are the microplastic. Secondary plastic, when they are degenerated from the bigger plastic like water bottle, grocery ball, synthetic clothing, car tires, and their tear and wear makes into the small particles. So when these particles are bigger, we can say that it is a major like 100 micron, 50 micron, 20 micron. They can be filtered out by some lymph node. When they are very tiny, 4 micron, which is less than the RBCs, they circulate and goes in circulation. So we have exposed, this is a very interesting publication, Microplastic and Nanoplastic in Cardiovascular Disease, an emerging cardiovascular, which is just published recently. And if it shows that if we have, if we have ingestion, I think it's not showing. Okay, no problem. So it is showing that we have a source which we can inhale. We can go to the lung, these nanoplastic. If we drink or eat, it goes to the GI tract, or by our thermal or skin, it can be absorbed. Like in this particularly, you can see that all these water bottles, the chelate microplastic and nanoplastic, longer they are, like they have expiry date of about 1 year. After a few months, they have 100 to 300,000 nanoparticles in them. So this recommendation reduce the expiry date. If they are exposed to sun, fast chelation occurs in these nano and microplastic. In Columbia University, they have shown that a standard 1 liter water bottle has 240 to 370 microplastic, and 90% of them are. Can we play this video? Yeah. So this is, with my little knowledge of AI, I created the video to show how a water bottle can disintegrate these chelating and microplastics. So in one of the research, they gone to the supermarket in US, collected 3 bottles from the different company, took to the lab and calculated the microplastic in them. And they found 110 to 370,000 in each, and 90% of them, they're nanoplastic. Most of them is polyethylene, which is obviously because these bottles are made up of polyethylene. Similarly, these are different types of plastic which is available in our day-to-day life. Polyethylene or polypropylene, like medical electronic equipments, straws, furniture. Polyethylene is mainly used for low-density form in bags, plastic wraps, and the high-density form, they are drainage pipe, shampoo bottles, detergent bottles. Polyvinyl or PVC, electrical cables, insulation, frames, pipes. Polystyrene are like foams, plastic containers, rigid trays, audiovisual cassettes, and polyethylene, they are bottles, vehicle tire, conveyors. So all these plastic there, but how they are going to check them, how to test them, these techniques are not there. Recently they developed, we call Raman scattering imaging platform, automated with plastic identification algorithm, by which they are calculating. If we put it in microscope, you cannot see them. So they have found out that these plastic, they have a special technique to find it out. We take from oral ingestion, dermal inhalation, and with medical equipments. We are also culprit and directly transmitting these nanoplastic to our patient by IV infusions, catheters, and intravenous catheters. These are the bisphenol and polyvinyl chloride, which is the part of this plastic, and they are there. So what is there? How they go to our body? Can go to direct circulation, go to the blood vessels, and thereby they're reaching to the heart. And in this interesting publication, in which what they have shown, that if we use the normal saline and 5% dextrose, and when we transfuse from 250 ml to 3 liter was transfused, and then they calculate the nanoplastic in the patient and in the plastic container. And if you see in this diagram that this nanoplastic was transmitted initially in a very rapid form, later on, after 1000 ml transfusion, the transmission was slightly low. Similarly, in this one, we have shown that when these nanoplastic, whether it's ingestion or digestion, goes in our circulation, they can cause changes in our mitochondrial oxidative things. They can go to change endothelial linings. They can create the changes into the cardiac directly by making the change of remodeling of the heart. They are involved in plaque formation. And this, on subsequent slide, we will show how they are shown in the plaque formation. In this particular study, they have exposed the rat for this polystyrene microplastic. And in this microplastic, what they have shown that when exposed for 2 weeks, and then dissected the heart. They found there is a significant ventricular myocardial hypertrophy and myocardial necrotic fibrosis in this group of the patient. In another test, the zebra fish were put in the 4 different tanks. One was control, second was 1 milligram per liter, and third one was 10 milligram per liter, exposed for 30 days. And then they taken out this zebra fish and their heart. And what they found, there is a significant distinct toxic effect in cardiovascular system. Their growth in the body retarded. There is a great reduction in the heart rate, severe impairment of myocardial cell density. Oxidative stress was very high with severe myocardial damage. They take the tissue pathology for histopathology, found myocardial fibrosis and apoptosis in the heart, just exposure of 30 days. They take 22 volunteers, check their blood, and they found out of 22 volunteers, majority have got particles, and these are healthy volunteers. In another study, they have taken the samples from the 10 volunteers, healthy volunteers, and they found 23 particles in their urine. Then they collected the tissue from the kidney and found 60 to 80% of human tissue has got these plastics. 4 out of 6, 4 placenta has microplastic. Urine samples, breast milk, 76% has microplastic. This is a very interesting publication, New England Journal of Medicine, where microplastic and nanoplastic was seen in atheroma formation. And there are 304 patients whose atheroma was participated. Out of that, 257 completed the study in 35 months. And what they have seen that the plaque has 150 of them has got atheroma, contains the plastic. They have done the electron microscopic, and in electron microscopic, they can see the plastic clearly. What they say, the patient, if they don't have plastic in atheroma, they're 60 times less likely to have a stroke and higher, 51 times higher stroke, higher chance of myocardial infarction if this group of the patient has plastic in their plaque. And here, if you can see, composite myocardial infarction, stroke, and death is by 24 months is more likely by 51% if they are carrying microplastic in their atheroma and plaque. This is the mechanism how this microplastic goes from the atheroma, and they are more liable to rupture the membrane, the covering of the plaque, and leading to myocardial infarction. In another study, this is the last 2 slides, microplastic was found collected from 15 different cardiac surgery patients, 6 pericardia, 6 pericardial adipose tissue, 11 pericardial myocardium, and all of them has shown microplastic in this group of the patient. So what is the take-home message? The take-home message is avoid plastic as much as possible by your life. It is impossible totally, you cannot avoid it. From clothes, from quilt, from this, from water, from bottle, everywhere it is. So first thing, start from your kitchen. Remove all plastic from kitchen. Use the wooden board, use the wooden boxes, metal boxes, glass metals. Use glass, metal, ceramic. So start from your home, start from the kitchen, start from your clothing. Use the tap water with filters rather than bottled water. As much as possible, avoid bottled water. Go natural wherever it is matter most. Cotton clothes, cotton shield, cotton quilt is superior than plastics. All these industries where they have shown plastic, probably as much as we can go to the natural and glass bottles. Ultra processed food, covering of the food with the plastic, avoid it, because they are leaching out all these micro and nanoplastic. All artificial fragrances has plastics. Indoor dust, these have plastic. Catheter tubes, FDA has noticed it, other societies notices, and they are doing changes how to rectify these plastic bags, plastic catheter, and what material they can do which should not leach the nanoplastic in the patient's circulation system. So whatever it is, we should avoid this exposure to the nanoplastics. Thank you.
Thank you. Very good, sir. We'll keep the questions to the end.
So next topic is for cardiogenic shock in 2026, evidence, algorithm, and advanced support. And Dr. Georgie Thomas is here. He's consultant interventional cardiologist, Burjil Hospital, Abu Dhabi. So Dr. Georgie, chair is your.
Good evening, everyone. And thank you, Dr. Mishra, for scaring the hell out of us for everything. So it's a nice evening. I think everybody's woken up from the afternoon siesta after lunch. Now it's tea time. Let's get on with this. Cardiogenic shock. It's a long, long, big topic, and I do not know how we can finish it in 12 minutes. Let's take it forward. Right, what happened? So, cardiogenic shock was introduced to us in 1999. We all knew about it, but a trial came with the shock trial. And the shock trial said and established that we have 50% mortality. And then that number has stuck with us like glue for the last 25 years. The needle doesn't change. No matter what trial you do, it is always 50% mortality, somewhere around that. What happened? IBP shock 2, 2012, 56% mortality. Impress, 2017, 48% mortality. ECMO CS, we thought we were smarter by 2023, 54% mortality. Euroshock, 2023, 49% mortality. ECLS shock, 2023, no way, you're still stuck at 53%. And then happened this great trial that actually moved the needle backwards, danger shock. And that was showing an in-hospital mortality of 46%. It was the first positive RCT in shock that showed a 180-day mortality of 45.8% in the treatment group compared to 58.5% in standard of care patients, with a risk ratio or a hazard ratio of 0.74. And this was durable to 10 years. And the 12.7% improvement improved to 16.7 or 16.5 at the end of 10 years. So the needle did move backwards. We did have the one trial that said that something was run right. So it just taught us that you need to use the right pump in the correct ventricle at the correct time in the correct patient. Brings us to the next thing. What are the stages of shock? Sky defines shock as A, B, C, D, and E. So we go back to LKG, right? Stage A, at risk. B is at beginning of shock. C is classic shock. D is deteriorating shock. And E is an So most of the patients that we deal with would be at stage A, stage B. Stage A is peaceful. It's only at risk. You might still get away. Stage B is the beginning of shock, and this is where we get caught because stage B shock can quickly turn to stage C. And these are dynamic. These entire stages are dynamic. What happens is overnight in 24 hours, the entry criteria may not be the exit criteria. So the entry may be at A, and by the time you get back to the patient, the next state may be at C. So it behoves us to be very alert as to where your patient is. So the cardiogenic shock working group define these stages, and you have a big list of numbers that you have to look at these numbers. I mean, you can confuse yourself looking at this, or you can download an app created by Navin Kapoor, and then you can put in all those numbers and calculate your stage and then modify your treatment. So there is a Skywalker, which is an app available freely, and it's designed for the iPhone. God knows when you'll make it for the Android. So what you need to keep it in mind is it is dynamic. It is not a label. Stage is determined by therapeutic efficacy. So if you are treating and you are in stage B and you add drugs to keep the blood pressure, you've gone to stage C. In stage C, if you add a mechanical support, you've gone to stage D. So these things are determined by therapeutic efficacy. The one thing that modifies everything in the stage of heart failure is cardiac arrest. Anywhere in ABCD, if there's cardiac arrest, you're done. The entire risk factor changes, it gets completely modified. Now, what do we use? We use lactate and its clearance. to monitor our efficacy of treatment. As the lactates come down, you know you're doing a good job. And as the lactates go up, your therapies increase, you make the patient worse, or the patient treats you worse. You lose your peace of mind. And stage B, as I told you, is the inflection point, is where everything changes. Therefore, the treatment rests on 4 pillars of cardiogenic shock. First one is unblock. We all know it as interventional cardiologists, unblock the artery. That is the only thing that has stood the test of time. Unblock the infarct-related vessel. So shock trial in 1999 showed us that you need to open the infarct-related vessel. And then that was reiterated in culprit shock in 2017. Again, multi-vessel AMI, but open only the infarct-related vessel, leave the others alone. So what did it show? On the left panel, we have the relative risk of the early shock trial in 1999, showed at 6 months out, PCI showed benefit to keep patients out of shock. And the culprit shock trial, the next one on the right, showed that if you go around fiddling with all the vessels in multi-vessels, rather than doing only the culprit, your overall outcomes are worse in multi-vessel PCI. You go back, you want to see death. Death also is worse with multi-vessel PCI in an MI scenario with cardiogenic shock. Go back. Do you think you'll save the kidneys? Definitely not. Even renal replacement therapy is more if you do more than the culprit vessel in an acute MI cardiogenic shock scenario. So the next most important part, squeeze the heart. Okay, don't squeeze anything else. Squeeze the heart. How? Pharmacologically. Pharmacologically means you will add vasopressor, inotropes, the things that you know, but what has changed? Your number one drug is norepinephrine, first-line vasopressor. The SOAP2 trial proved that dopamine is a disaster. It causes more arrhythmia, causes worse survival. So dopamine has been abandoned in cardiogenic shock. Epinephrine has moved to reserve-only status. Norepi is what is used. In the optimal CC trial, they showed that the epi caused far more refractory cardiogenic shock, up to 37% more versus norepinephrine. So the trial was stopped early. Milrinone and dobutamine can be used carefully, wherein we know the evidence is from the DOREME trial. Choose by physiology. Basically, milrinone helps within beta blockade, whereas dobutamine helps with faster titration. But remember, whatever drugs you use, it is a trade-off for using using high metabolics, which means the MVO2 increases, arrhythmiagenicity increases, myocardial toxicity increases. And it will trigger you to go on to the next level, that is mechanical support. So coming to number 3, the pump, support mechanically. Now, mechanical support is not, MCS is not a one-size solution. Use a pump for everybody. No, that's what the danger shock trials showed us. The IABP era is over. The Europeans were actually saying, put it in your museum and keep it as a age-old device. But for us who use IABP, we know that in some cases it still does help. And that is the only support many of us have in our cath lab. Impella was a breakthrough. The danger shock trial actually proved it. The first MCS device to actually say something helps in cardiogenic shock. VA ECMO, it's a selective issue. It's a very, very selective thing. You should know where to use it. And it's a rescue tool full of trouble. Loading versus unloading. You can load a ventricle by giving it an ECMO, or you can unload a ventricle with an Impella. So the landmark trial was danger shock. It designed and looked at 360 patients across 14 sites in Denmark and Germany. STEMI only, LV dominant, excluded comatose and post-arrest patients, showed 12.7% absolute mortality reduction at 180 days, with a number needed to treat at 8 patients to save 1 life, which means it is still going to kill 7 patients to get 1 patient alive. And there is at a cost, significantly more bleeding, more vascular complications. And in spite of all of this, danger shock at 10 years, the curves kept separating and showed that there was a 16.3% absolute mortality reduction at 10 years, adding 600 days to everyone who stayed alive on that trial. So what more do we know? we know that there is something called as a phenotype in cardiogenic shock. You need the different trials from the cardiogenic shock working group and the validation on the Danish National Patient Registry showed there are 3 types: non-congested, cardiorenal, and cardiometabolic. So the guys who are in non-congested heart failure or the non-congested subgroup, they did the best. Cardiorenal, subsequent, and the cardiometabolic, the worst. So this is defined, and this is looking forward, we might be able to tailor our therapies based on this. This is a graph that shows collective mortality. See, the worst is the cardiometabolic. Routine VA ECMO disappoints in unselected AMI cases with cardiogenic shock. 47% mortality compared to 49 with heavy bleeding, and the bleeding was almost double in the group. And all the meta-analysis says no use. Don't use VA ECMO unless you know how to use it. What is it? Because cardiogenic shock is stratified by, oh, sorry, did I go back? What happened? Yeah. So what happened actually, because ECMO loads the ventricle, you're increasing the afterload on the ventricle, increasing the MVO2, and a failing ventricle is getting more work. So in an ECMO, you need to vent the ventricle with an impeller. So the term ECPella. Whereas an impeller is a microaxial pump which actually augments forward flow, unloads the ventricle, and gives the ventricle some time to rest in between the 2 beats. And it's more physiologically aligned. So what do we have? From Escalate everyone, the change is now match your device to the patient. Impeller, class 2A recommendation. IABP, not a routine, but what else do we have in our labs? VA ECMO, highly selective based on whether your oxygenation and the values are there. So early recognition is, and prompt selection is in a tailored MCS protocol. The first 24 hours are decisive. Stage B always gets worse. Plan the exit. If you're going to do a device, start by planning when are you going to remove it. Have your escape plan ready before you even start it. And that brings us to the last pillar, organize. We are all good at revascularizing, but the shock team, when the patient gets into the lab, you should have point number 1, organize your SCI team, organize your SCI group. Whether there is lactate, you should be classifying the patient to A to E. Number 2, fix the cause. That is, fix the problem that started it, revascularize. 3, stabilize the patient with whatever drugs you know, Norepi first, and then the inotropes. Then get the numbers. The PA catheter is back in vogue, so get your numbers from the PA catheter. You can also get the PAPI. That is a definition of the pulsatility of the RV output that helps you to determine whether there's an RV failure or an LV failure. In LV failure, STEMI plus LV dominant, impeller is the way to go. RV failure, you have a different support device for the RV. Don't try to use an impeller in an RV failure. And ECMO is a rescue thing that if everything is failing, mostly like a cardiopulmonary bypass, usually the patient will not make it because stage E has an 80% mortality. And as I said, serial lactate helps you determine whether your treatment is working or not. Do not hesitate to refer quickly to a team that does this regularly rather than to be the hero on your own. Few other things that I've just was looking around. One was an ESCAPE trial, which actually proved that use of the PA catheter actually helps in determine outcomes. It's back in vogue, is the best thing to do. And the last thing, something that looks a little better than the impeller. It's called the Elevate device, which actually is a 30F device compared to the 14F that we use, but it goes in from a 10 French, it's a 10 French guide, and the impeller opens up because it's a nitinol wire.
Can you wrap up?
Done. Impeller is, this is something that's similar. It's a first-in-man trial. They were able to see this with a 30F guide. And probably they were able to get good outcomes from the groin and stuff. But that's where the future looks like. And that is the end of a very difficult topic. Thank you.
Thanks for wonderful lecture. We are keeping question for the after session.
Don't ask.
And the next talk is COVID-19 and the Heart, Myth and Realities by Dr. Ajit Jain, cardiothoracic surgeon from New Delhi.
Good evening, colleagues, distinguished faculty. Today, I'm going to talk about COVID-19 and the heart, myths and the realities. I have had the privilege to work as consultant in charge for the COVID-19 patients at a COVID-dedicated hospital, tertiary care center, Rajiv Gandhi Super Specialty Hospital. I have had privilege to work as nodal officer for COVID-19, as well as nodal officer for vaccination and AEFI monitoring. So I do have the experience regarding vaccination program and regarding basic treatment program. I came here from New Delhi, the city that has known great suffering from this pandemic and great resilience in its aftermath. What I have learned from those patients, from standing at bedside, from reading the CMR reports, from signing the death certificates, is that COVID-19 demands our best cardiology. In our hospital, we have collected vast data, analyzed it, group discussions, seminars. We have had more than 20 publications on COVID itself from our hospital. Out of those many publications, 4 have gone from my table. These analysis, publication, data collection has given us insight, and that has reflected in our results and yielded the fruits. Our COVID mortality was minimum, probably minimum on globe, just 7 and 6%, while the other institute, medical colleges of Delhi, they were having up to 81%. This data analysis has also given us the insight to come up with the first post-COVID clinic of India. These data analysis got published in national and international letters and got national and international media coverage too. These results published at Washington Post, in Netherlands, Sweden, Straits Times Singapore, including Gulf News. So today I'm going to cover why the heart matters, pathophysiology, myth busting, COVID myocarditis, cardiac injury and mortality, vaccine safety, long COVID and diagnostics and return to play. The core scientific reframe of my lecture is COVID-19 is not pneumonia. It's a systemic vascular disease, manifestation of thromboinflammatory syndromes, endothelial disease, microvascular ischemia, and cardiopulmonary interaction. The figure which you are seeing 60%. 60% are those patients whose CMR has shown the cardiac abnormality. These patients were recovered patients. So it is beyond imagination that COVID was causing cardiac manifestation in 60% of cases. The SARS-CoV-2, as we all know, that it enters by AC binding and TMPRS has membrane fusion. ACE2 receptors are highly expressed in cardiomyocytes, cardiac pericytes, and coronary endothelial cells. The heart is not an innocent bystander. It's a primary target because it's a systemic vascular inflammatory disease. It affects direct and indirectly to the cardiac myocytes. The cytokine storm causes the indirect injury by inflammatory myocardial injury, arrhythmogenesis, right ventricular strain, and specifically the type 2 myocardial infarction. It's just because supply-demand mismatch, coronary vasospasm, microvascular inflammation driving subendocardial ischemia. These ACE2 and TMPRS and RAS dysregulation by direct and indirect injury to cardiac myocyte manifest in different ways. If we see the cardiovascular disease, particularly hypertension, coronary artery disease, and diabetes, we see that cardiovascular disease and COVID-19 are not simply comorbid conditions. They are mechanistically entwined. A patient with hypertension, diabetes, coronary artery disease, and COVID-19 is not just a hypertensive or diabetic or CAD patient who also has COVID. They are a patient in whom both diseases are amplifying each other's destructive potential simultaneously. So these are the different manifestation. This central illustration was published by Walsh, that manifestation because of this virus is all kinds of arrhythmia, thromboembolism, coronary event, and heart failure. So I'm coming to myth number 1. The evidence which has been produced in different papers shows that no randomized trial has ever shown benefit from stopping the AC inhibitors or ARBs, and ACC, ESC, and WHO all recommended continuing the guideline-directed medical treatment. Because in early pandemic, we all were confused that whether we should stop these AC inhibitors or not, because these inhibitors are associated with the upregulation of AC2 receptors. The myth number 2, that COVID is only a lung disease, the heart is not affected. As Patman and all, they have published their first original study in JAMA Cardiology 2020, shown that 60% of recovered patients has shown abnormalities in their cardiac magnetic resonance imaging. Coming to myth number 3, that only patients with pre-existing heart disease are at cardiac risk from COVID-19. Again, which was proved wrong, because that same paper, Patman and all, which has published, has shown that 60% patients, they were not having any previous cardiac disease. And regardless of this prior CVD, they have shown the cardiac abnormalities. Now coming to the COVID myocarditis, 2.4 to 7% incidents were reported by the European Society of Cardiology in 2022 in their position paper, that COVID-19 myocarditis is a well-established disease. And they have used the Lake-Lewis criteria, updated 2018, which was having a more specificity and missing the less cases of myocarditis. Now coming to the COVID-19 vaccine, which has created lot many misconceptions. We heard from our colleagues, from patients, from attendants, and they were refusing for this vaccine. The vaccines which we have used, mRNA vaccine, this was the first time, viral vector, whole virus, and protein subunit vaccines. The efficacy of mRNA vaccine, Moderna was 94.1 and Pfizer was 95%. As we have seen that these vaccine-related myocarditis were mild in nature and almost more than 95% fully recovered, while the COVID-19 myocarditis, it can be severe or fulminant, require intravenous immunoglobulin, steroids, everything. And 10 to 15% patients, they converted into chronic LV dysfunction patients. So coming to the myth number 4, that mRNA vaccine commonly causes dangerous permanent myocarditis that outweighs their benefit. But in reality, vaccine-associated myocarditis, as we have seen, predominantly mild and self-limiting. So the vaccine does not cause more cardiac injury than the disease it prevents. I'm just quoting the paper of Shi et al. It was their original work published in 2020. This paper came from von Rennman Hospital and has given us an insight how to deal with these patients. And this paper has been discussed thoroughly in our hospital multiple times. They have selected 416 patients out of 1004 patients, out of which nearly 20%, 19.7% patients were having cardiac injury, and nearly 80%, 80.3% patients, they were not having cardiac injuries. If we were seeing the patients who were having hypertension, diabetes, or cerebrovascular accidents, or chronic renal failure, or chronic kidney disease, COPDs, more leukocytosis with lymphopenia, increased CRP, troponin, CPK-MB, anti-pro-BNP. These were the indicators that these patient needs special attention, needs the cardiology's full toolkit to diagnose and to pay attention to them, because they are the patients who are going to die maximum time. As we have seen in the treatment complication and outcomes, these patients who were having cardiac injury required more mechanical ventilation, associated ARDS was up to 58.5%, and their death was 51.2%. By the end of 4 weeks, we have lost 50% of patients, while those who were not having the cardiac injuries, just 4.5%. This Kaplan-Meier curve is showing the same. This red line, by the end of day 7, we have lost 20%. By the day 14, second week, we have lost more than 40%. And by the 28th day, more than 50% with cardiac injuries. That's why I'm saying COVID-19 is not pneumonia. Who is the highest risk at cardiac risk? In last slides, we have seen that hypertension, diabetes, obesity, male sex, older age, and lot many other factors were associated with the highest risk of the death. Arrhythmias, all kind of arrhythmias were caused by COVID-19. Al-Alai has shown that 45% patients were having mechanical manifestations, different mechanism for the manifestation of POTS, persistent inflammation, myocardial ischemia, endothelial dysfunction, elevated event risk, and rehabilitation needs. So long COVID is not a myth. It is established by this paper where they have shown that 45% is having elevated 1-year cardiovascular risk. Myth number 6, that asymptomatic athlete need no cardiac evaluation before returning to sport after COVID-19. But graduated return to play protocols are mandatory. These are the tools which we have used, that any patient who is even athlete, who is COVID-19 positive should be on rest for 10 days. ECG troponin has to be done of symptomatic patient, in case needed echocardiography and CMR, and graduated return. The diagnostics in the post-COVID cardiac evaluation toolkit, what we are having to be used in sequence: the ECG, troponin NT-proBNP, echocardiography, cardiac MRI, PET imaging, and ambulatory monitor. The key takeaways for cardiologists is COVID-19 is a systemic vascular disease. Myocarditis is real but manageable. Vaccine safety is established. Long COVID demands surveillance, and structured protocol now exists. So we have to keep ourselves updated because evidence keep on evolving. Thank you for your attention. Thank you.
Thanks for completing on time. Any question from the audience for all these 4 speakers?
You recommend COVID vaccination even now?
Yeah.
Discussion. Yes, please.
One question. Do you recommend COVID vaccination even now? Because some government present status of COVID vaccination for prevention, are you recommending that vaccine should be taken now?
So he's asking, would you recommend COVID vaccine at a long-term basis? To whom?
Basically, like today, we have seen the paper of Dr. Gupta, who has said that class 1A indication of influenza vaccine, pneumococcal vaccine, and he has added third one, COVID-19 vaccines. And same we have seen and we have felt that after giving COVID vaccine, those who got the COVID vaccine, they were having less chances of cardiac injury. So we can recommend. But we are not having enough data to say that we should be going for it. But definitely, the person who got the COVID vaccination is having less chances of cardiac injury.
Any other questions? I think there is no question, so we finish this session and next session will start.
Thank you.
Thank you so much. That was a very nice presentation from all the speakers. Dr. Ajit showed a very nice slide of final slide is actually quite good. Yeah, just wait, please. And we are almost on time. We'll just felicitate this session's speakers and moderators, and then we'll go on for the next session. So, and which is the last session, and only hardcore people will be attending those. So, Dr. Abhay Nigam, he is the first timer in our conference, and thank you so much for delivering a wonderful talk and coming over.
Thank you so much.
Please. Dr. Mishra, please. These all are recorded and will be posted actually on the website and YouTube, and anybody can watch later. Dr. Georgie. Dr. Georgie, you are as good a speaker, as good a wonderful. Very nice. And Dr. Sundar. That's all. Last.
Yeah, what we have for the checkers.
Yes. Oh, Dr. Ajit Jain. Dr. Ajit Jain. Thank you, Dr. Ajit. He's a hardcore cardiac surgeon, but now he's labeled as a COVID doctor because 1.5 years he continuously worked in the COVID hospital. Oh, he's not here. We only have Dr. Sundar. Dr. Sundar, thank you. All those who are here, please stay over for our last 30-40 minutes. So two of the most prolific speakers will be speaking now from USA. And are we ready, the team? Are they online already?
Yes.
So first I will call upon the chairpersons, Dr. Thayer, Dr. Rahul. Dr. Rahul is not here. Dr. Georgie. Dr. Srinivas, please join us. So the format is that lectures are pre-recorded and they will be played, but the speakers are available online for interaction. So please take on the session.
Yeah, good evening, friends. I think we are all excited to listen to Dr. Fayaz Shah. We grew up seeing him, watching him as a role model, and thanks, Vijay sir, for arranging this lecture. And I was also told that he'll be available physically also to clear our doubts or if you have to ask him anything. And the title of its talk also looks very impressive, Surgeons and Interventionists, a collegial collaboration. That's how we day-to-day work, especially in the structural heart interventions and the complex coronary area. I think he's ready, sir. Shall we go?
Is Dr. Fayaz Shah fine?
Yes, I'm here.
Surgeons and Interventionists, collegial collaboration. Is Dr. Shah online? Can anybody tell me?
Yes.
Yeah.
Good afternoon, friends.
Good evening and good morning to you. So we have Dr. Srinivas, Dr. Thayer, and Dr. Georgie, the wonderful team, and we have the hardcore listeners now, those who really want to attend the meeting. We had a wonderful meeting so far, but as you know, by the end of the day, the crowd thins out. So those who are remaining are actually those who are really keen to you. So
No,
we
I
will
have
start
listened all your talks and congratulations. I am really impressed that you have stressed this year about prevention. I think we
Thank
have
you.
prevention. My talk wouldn't be there.
Thank you, sir. Thank you for your time. We're eagerly waiting to hear to your talk. And after the talk, I think we'll request you to clear any questions if you have.
My
Can we have the talk? Thank you.
Please start.
Hi, good afternoon, friends. Dr. Mittal, thank you very much for your kind invitation. I'm speaking on a very interesting topic, surgeons and interventionalists a collegial collaboration. I have nothing to disclose financially. So I'm going to start with a case example where I would say both the heart surgeon as well as interventionalist made a decision what is best for patient's outcome. First is an example here, patient 66 who presents with anterior STEMI. You can see his right coronary distal RCA is occluded, which is chronic. But what he has is, you can see it here, very diffuse LAD, multiple stenosis. And it was, you can see here, he had an excellent PCI, did very well. He was discharged on day 4th, and the echo showed an ejection fraction of 45%. So he was discharged on guideline-directed medical therapy. However, he comes back 2 months after his anterior STEMI with angina class 1, actually. And he had a stress test with his cardiologist that showed moderate size infralateral ischemia at 6 mets. So what happened now, he had an outpatient cath, which we are watching. And what shows here, the LAD is widely patent, but there is definitely a suspicious lesion in the ostium of the left main. So rightly at the time of catheterization, he had an intravascular ultrasound that showed critical left main with an area of 4.8 millimeters square. This interventional decided to send this patient to surgery, graft to that CTO of the RCA, left circumflex, which is really a large vessel, as well as the distal LAD, although not ideal, but as well as the diagonal branch. But it was an elective procedure. Patient was discharged after cardiac cath, and he was scheduled for an elective bypass graft surgery in 2 weeks. However, 3 days prior to elective CABG, he presents to the emergency room here with prolonged chest pain and with new EKG changes. I will show the electrocardiogram in a minute, but he rapidly deteriorates with acute heart failure, hypotension. He was intubated, started on inotropes, and was transferred to OR for urgent CABG. This is his first electrocardiogram in the emergency room with chest pain. You can see here he has marked ST elevation in AVR, one of the features of left main occlusion with some diffuse ST-TF changes. This is when he became more hypotensive, heart failure, chest X-ray. He's in heart failure, and EKG shows now a wide QRS with, again, persistent ST elevation in AVR. It's just before going to the operating room. Now, in the operating room, he had a TE done. You can see here he has very severe LV dysfunction. And before the surgery, he sustained refractory cardiac arrest due to the current VT, VF, multiple shocks, which occurred after induction of anesthesia. He was rapidly placed on ECMO through femoral access while chest compressions were in progress. So he was placed on ECMO, as I showed you earlier. TE shows poor LV function, and we had a discussion. I was called in, was felt that we know his anatomy is the left main occlusion, and with his cardiac arrest, poor LV function, we decided that we should abort the surgery and refer him to me for PCI to the left main. So we brought him down to the cath lab, which took fairly a long time. You can see 1 hour and 42 minutes from emergency room to ER, but from OR to cath lab was 18 minutes, and cath lab to PTCA to left main was 21 minutes. Now this is the groin shot showing on the right side. He has got venous and arterial cannula. I went from the left femoral axis and I did the angiogram of the left coronary artery. As expected, he has left main occlusion with very poor flow. And note there is a contrast in the sinuses. What that means is that there is no LV ejection. He's totally dependent on ECMO. But anyway, rest was very easy. We crossed with the wire and we did the interventional left main single stent. And you can see here, he did very well. After we got an IVUS area 10.6 post left main, and his blood pressure was 110/60 now on ECMO, just 3-liter flow, and we put him on a balloon pump as a venting as he's on ECMO, and this is electrocardiogram post PCI showing improved electrocardiogram. So the next day after his PCI, he's awake. He moves all his extremities, excellent urinary output, a normal creatinine, but we could not wean him off the ECMO. Each time we tried to reduce the flow rate, his pressure drops, and echo shows LV is dilated. I think that's typical of when you have an ECMO for a long time. There's increase in afterload, preload. You have to vent these ventricles. So we recommend that we're going to do an Impella on him as an LV venting device. So we removed the balloon pump and we use Impella. CP was instituted, and just to let you know, his LVDP was 45 at that time, prior to the Impella insertion. Impella is excellent for unloading. Now we call this Impella and ECMO as ECTALA. Anyway, he was weaned off ECMO and then Impella in 5 days and was discharged 2 weeks later with an echo EF of 40%. And at his last follow-up at 2 years, he remained as a New York Heart Class 1 on guideline-directed medical therapy. And this is echocardiogram. You can see is some apical hyperkinesis distal septum, but very good-looking LV, at least 40%. Now, next is somewhat very unique case. Another case who presents with STEMI. This case is only a 53-year-old male, presents with inferior STEMI, but with stable hemodynamics. He has history of hypertension, diabetes, and as I will show in a minute, cath showed totally occluded right coronary artery, which is the culprit for his inferior STEMI. But he has critical left main, LAD, and circumflex stenosis. When he came to the emergency room, he had received Brilinta aspirin as per protocol, and he was hypertensive and was started on IV nitroglycerin, and patient in the cath lab was awake with minimal chest pain, and the operator who was on this case did the angiogram. You can see here he has occluded RCA for his culprit vessel for inferior STEMI. Blood pressure was 160/80. But the problem is here, he has very almost 95% distal left main before bifurcation and multiple lesion in the LAD, very small caliber LAD, and multiple lesion in the AV groove circumflex. So what this operator did rightly, it's inferior STEMI, he opened the RCA, but he decided to do a balloon angioplasty of the RCA, and he referred the patient to emergency CABG, which in my opinion wasn't right, as I will talk to you shortly. Anyway, he did the PTC of the RCA, and patient went to emergency CABG for in the operating room, and he did put the IABP before going to OR. Now, if you can see here, the balloon pump was inserted, and patient is stable. Right coronary is open, but PTCA, not stent. But what happened is patient sustained cardiac arrest after stenotomy, open cardiac massage, placed on central ECMO, and the TE shows an EF of 10 to 15%. And he has an open chest. Now this is here, you can see open chest, and not much motion of the heart. And this is the TE on central ECMO, shows EF about 10 to 15%. So as called, and we had a what we call heart team discussion, what is best for this patient? As you know, that he had an open cardiac massage, TE showed EF of 5 to 10% on central ECMO. And when I was called in, the surgeon, my colleague, felt that since he had already open RCA, the only vessel now is that the best target is LAD, left main, and restent the RCA. But we also looked at the films, I'm going to show you in a minute, and the LAD appears as diffuse disease and not an ideal target for bypass. So discussion in the OR was, as a heart team, let's proceed with PCI to left main, LAD, since LAD is not a good target, as well as extend the RCA. So patient was then taken to the cath lab with open chest, which was taped, and was left on central ECMO. Now, the hemodynamics prior to coming to cath lab, he had minimal LV ejection. Mean blood pressure was 65 on large dose of inotropes, plus, of course, central ECMO, but good flow, 4.5 liters a minute. So this is the patient being prepared from the operating room to the cath lab. It took a long time to transport such patient on ECMO to the cath lab. This is the cath lab patient getting ready for intervention, remains on central ECMO, and the IABP is still in. If you remember, he had an IAB put in before surgery. This is my team, cath lab. So this is now in the cath lab. You can see a lot of equipment there, the central ECMO, venous cannula. So first thing I did, I want to check the right coronary artery. Being hold, the right coronary is totally occluded now. So he had already a radial sheath in, so I went to the radial JR4. We opened the right coronary artery, which was very easy procedure. But note, he has collaterals from the right coronary artery to the circ and LAD. So stenting that RCA alone wasn't a great idea. Anyway, we tried to do the right radial for the left coronary, but there was a severe spasm because he was on inotrope. So I decided not to do radial. I went from the left femoral, put the JL guide. You can see JL guide here, and you can see here tight distal left main, very poor flow to the LAD, and LAD is diffusely disease. Make a note. I think that was one reason my surgical colleague and we decided it'd be better to intervene this vessel because it's not a good target for bypass graft surgery. So it was a very difficult procedure because the LAD was diffusely disease, calcific. I think first time I had to use only 1.5 millimeter PTCA balloon, required guideliner. To make long story short, we were able to do a good results of this distal left main without compromise of the ostium of the circ, without compromise of the ostium of the LAD, and the ramus is patent. And we went ahead and this is the final picture. We stent the left main, LAD, proximal, mid, and distal with excellent flow to the LAD. At this point, after the intervention, I did an LV gram. You can see he has very poor LV function. And his LV EDP was 56 millimeter mercury. So when you see on ECMO, very high LV EDP, 56. he can't come off the ECMO. We have to vent this ventricle. In the olden days, I'm talking when I was in the 80s and 90s, there was no Impella. I had custom made 9 French pigtail, and I will hook the 9 French pigtail to the venous inlet of the ECMO so we can suck the blood from LV as a venting. But now we are in 21st century. I was able to place Impella on this, which is an excellent unloading agent. So after this procedure, PCI, the left main, LAD, and right, Impella, this is electrocardiogram post, shows a definite improvement in his ECG. And this is the ventricle. Again, this is on ECMO and Impella, very little motion. So what it needs is time. It just shows you data from JACC 209 that if you have a cardiac arrest in the emergency room or in the operating room, much higher survival and much higher neurological recovery. But if you do out of hospital arrest, ECMO really, unless is not great and survival is poor. So what happened to this patient is, as you know, he has a central ECMO. So patient went back to the OR, chest was closed, central ECMO was replaced with peripheral via ECMO. He went to CCU with stable hemodynamics on ECMO and Impella called ECPella. Guess what? He remained on VA ECMO for 5 days, and Impella was removed after 8 days. Unfortunately, he did have compromise of the right common femoral artery on ECMO side, which was repaired surgically. He was finally discharged 4 weeks later to rehab with the EF of only 20%. But 3 months post-discharge, he returned for an ICD implant and remained in New York Heart Class 1 at 4 years. Now, just quickly, the role of bypass graft surgery in acute STEMI is not good. I think CABG in acute STEMI should be reserved for those people where PCI is not feasible or has been unsuccessful, or there's a hemodynamic compromise because of mechanical complication like papillary muscle rupture or VSD. But left main occlusion, like these both cases with cardiac shock, has very poor outcome with bypass graft surgery. Now, results of CABG in the literature for acute MI, the mortality is very high, 5 to 25%, and cardiogenic shock is the major predictor of early mortality. But if I have a patient, who needs surgery, it's better to delay it. I think if you look at the data, if somebody does need surgery, if you delay by 24 to 48 hours, they have a better outcome than taking acute surgery. And so, in conclusion, timing of bypass surgery, acute STEMI remains the key factor. Now, what is the take-home message from these 2 cases I showed you as a, surgeons and interventionalists collegial relationship? I'm from the days of balloon angioplasty from Andrea Grunzig. We would not do intervention, I'm talking balloon angioplasty, without surgical backup. Now we have come that we are in a stage where both surgeons and interventionalists can have a collegial relationship and do what is best for patient outcome. So my take-home message is a rapid collaboration between cardiac surgery and interventional cardiology can be life-saving during catastrophic surgical complication. Percutaneous intervention can serve as an effective rescue strategies when surgical options are limited or exhausted, like the 2 cases I shared with. And we know hybrid surgical percutaneous capabilities are essential in modern tertiary cardiac centers. Finally, early recognition of complication and immediate mobilization of interventional expertise are key to patient survival. Thank you very much. I'm more than happy to answer any questions.
Thank you, sir. Great cases, great saves. Actually, at the end of the first session in the ACS, I just mentioned the same. Surgery in the acute setting should be acute MI setting should be avoided only unless there is a mechanical complication. It's not easy. Our surgeons also would hate us if you send patients. That's what you showed because mortality is high. But in the first in case, God didn't want those patients to have surgery. When you are there around, actually PCI could be offered. Unnecessarily surgeon shifted, it all became a little mess. But otherwise, if you seen that first, after opening the right coronary artery, there's no point sending the patient for CABG because it could have been as well revascularized percutaneously. That's what exactly I mentioned in the morning talk. After that, we should as well try to do percutaneous procedure in today's era. I think with the better quality stents coming, I think most of the patients do well. If you see that, where you had a left main, some osteal disease, that stented segments remained all right. That is the beauty of regulating stents, which maintain good results. I think congratulations, great cases. And then that reiterates our idea of avoiding surgery in acute MI. Thank you, sir. Yeah. Question from the audience, sir. Please go ahead.
Sir, I'm just curious to know that once after doing the PCI, patient was shifted to OR and they have closed the chest. Why you didn't ask them to put a venous graft on the circ or OM? A venous graft on circ or OM?
Which patient we talking? First one, the second one?
Second patient, in which you have done the RCA and the left main LED.
Yeah, but if you look to the films, there was an AV groove circumflex, very small modular branch. The key thing was the LAD and left main and the right. Plus, the reason the patient had cardiac massage, AF was 10%, and it was felt he couldn't even bypass the LAD. It was so diffuse disease. And the right had occluded because they have to cross clamp the aorta. I think once your AF is down to 10 to 15%, you cross clamp the aorta. Patients on ECMO, the prognosis is dismal.
I think we have already come in a circle where we used to take surgical help. Now the stent with the technology, stents being there, we are able to save some of the surgically difficult to treat patients. Great cases.
Well, it just tells you that what you do, what is best for the patient.
Yes. Thank you.
That's the bottom line.
Thank you. So that's a great pleasure, Dr. Fayaz and Dr. Thayer. You can give some comments, then we move to the next lecture.
Nothing to say.
Okay. We can we move on to the Dr. Shawl? So great to see you, and I hope you are staying more for next lecture. That's from Professor
I'm going
Giuliano.
to stay. I've been, Dr. Mittal, I have been whole day listening to your talks. I learned so much about prevention.
Thank you.
I think I'm glad, Shakeheart used to be all acute intervention. I'm so happy and congratulate you for putting prevention. I think that's the best now, starting very early and avoiding these late events. So congratulations and thank you.
Thank you. Next year, please, you have to be in person. You should come in person.
Hopefully next year we'll do that.
Thank you. So shall we move for the next? Let's give a big hand to Dr. Shawl actually before.
Okay.
Yes.
So now we'll move to the last speaker who definitely doesn't require any introduction is Professor Roberto Giuliano, who is senior investigator of team study group and staff physician cardiovascular division, Brigham and Women Hospital in Boston, United States of America. He will present a precision prevention in dyslipidemia, ipilimumab in Vesalius CV, and results seen in core TIMI 72 trial. We are excited to hear from you, Professor.
Yes, good evening from Dubai and good morning in Boston, I believe. So this is Dr. Mittal and happy to see you online.
Yes,
Thank
likewise.
you.
Sorry I couldn't join you
Thank
in person.
you once again. So before we start your lecture, this afternoon we had a small felicitation, and this being the 10th annual conference in the series, we handpicked some very prolific faculty, and we have given a token of appreciation in the form of fellowship. So I'll just present the certificate to you online, and which we can send you later on. Thank you. Can I have the certificate, please? Can you see it? The camera? Give a big round of applause. Thank you. So please, you can start the lecture now. Please play the lecture.
Hello, my name's Robert Giuliano. I'm a senior investigator at the TIMI Study Group and a senior staff in cardiovascular medicine at the Brigham and Women's Hospital, as well as a professor of medicine at Harvard Medical School. And I'm very pleased to participate once again in the Shakeheart annual meeting. This is the 10th annual conference, of course, as you know. And sorry I couldn't be there in person, but I'm pleased to once again participate and deliver today's lecture on precision prevention in dyslipidemia, evolocumab in Vesalius-CV and olezarsen in the core TIMI-72 trials. Here are my disclosures. And the lecture outline is as shown here. I'm going to start with the Vesalius-CV trial, which was a study of evolocumab in patients with no prior MI or stroke. I'll go over the main trial results and results in 4 key subgroups. And then we'll turn our attention to triglyceride lowering in the core and core 2 TIMI-73 trials with olezarsen. This is a drug that targets the ApoC3 protein in severe hypertriglyceridemia. As you well know, 2 landmark trials with PCSK9 monoclonal antibodies demonstrated their efficacy to reduce cardiovascular events in high-risk patients. And FOYE was stable patients with ASCVD who received evolocumab, and Odyssey Outcomes, alirocumab was studied post-ACS. Now, those 2 trials were studying patients at the high end of the risk profile of patients with major ASCD events, either recently or in the past, such as prior MI or stroke or symptomatic PAD, plus other risk factors. In the Vesalius-CV trial, we wanted to study those that were a little lower risk, more in the middle group here, either those with atherosclerosis, but no prior MI or stroke, or even those slightly lower risk than that who had risk factors, including diabetes, but no known significant atherosclerosis. The main results of the Vesalius-CV trial have now been published in the New England Journal, but I'll walk you through the key findings. The study included over 12,000 patients at high risk for cardiovascular events without a prior MI or stroke. They had to have an LDL of greater than or equal to 90 milligrams per deciliter or a similar level of non-HDL or apolipoprotein B. They were on an optimized statin therapy. They could also be on ezetimibe. It was an event-driven trial with median follow-up planned to be over 4.5 years. And again, the entry criteria were coronary disease without an MI or cerebrovascular disease without a stroke, PAD, or just high-risk diabetes. Patients were randomized to evolocumab or placebo in a blinded fashion 1-to-1. And there were 2 primary endpoints. The dual endpoints were time to coronary heart disease, death, MI, or ischemic stroke, a 3-point MACE, or the 3-point MACE plus ischemia-driven arterial revascularization, or a 4-point MACE. Evolocumab reduced the LDLs as expected from an average of 109 at week 48 to 45 milligrams per deciliter. That's a 55% reduction, or a reduction of 63 milligrams per deciliter, about 1.5 millimoles. Evolocumab significantly reduced both of the dual primary endpoints, the 3-point and 4-point MACE, by 25 to 19%, and a variety of the key secondary endpoints, the composite endpoints shown, again, 21 to 27%. Each of these were significant. And as for the individual endpoints, myocardial infarction, ischemia-driven revascularization, and several of the mortality endpoints were reduced, but not quite significant for coronary heart disease death, although consistent with the other mortality endpoints. And stroke hazard ratio of 0.79, you see just missing statistical significance. So rather robust reductions in these important cardiovascular events. Most importantly, evolocumab reduced mortality from 9.7% to 7.9%. That represents a 20% reduction with a p-value of 0.0005. So we see Vesalius in this kind of middle range of the risk profile was effective to reduce cardiovascular events and including mortality events. I want to focus now on a very key subgroup of those patients who had no known significant atherosclerosis. They all had diabetes plus another risk factor. So these high-risk diabetics, no CAD, no CVD, no PAD of significance, but they did have high-risk diabetes, which included one or more of the following: duration of diabetes of at least a decade, or daily insulin use, or microvascular disease. Here are the endpoints for the no significant atherosclerosis group in Vesalius CV. You see the primary endpoints, 3-point and 4-point MACE, reduced by 31%. The secondary endpoints are reduced by a similar degree, and even directionally consistent findings for reductions in MI, ischemia-driven revascularization, the mortality endpoints, and ischemic stroke. Now, the confidence intervals are broader in this subgroup because there were only about 6,000 patients in this subgroup, but you see the significant findings. Now, as you know, the 2025 focused update of the ESC guidelines came out with the following key figure. And what I'd like to see in 2026 is that we update these guidelines, a 2026 version. We could call it the refocused update of the 2025 update to the 2019 guidelines, and move that high-risk category, such as what was studied in Vesalius, down to a target LDL of less than 1.4 millimoles, or 55 milligrams per deciliter. Now, since the main results were presented and the key subgroup, there have been 4 additional subgroup studies presented on June 7th at the American Diabetes Association. Was this analysis in all of the diabetics enrolled in the trial. So this included not only those without significant athero, but even diabetics with significant atherosclerosis. So a little over 6,000 patients were studied. They all had at least any one of the following: microvascular disease, chronic insulin use, or duration of diabetes greater than 10 years. 2/3 were on a high-intensity statin and almost a quarter on an SGLT2 inhibitor or GLP-1 receptor antagonist. About 3,000 in each treatment arm. You can see in the far right panel significant reductions in the 3-point MACE, and at the bottom right, the 4-point MACE of 41 and 31% reduction. And then second important recent presentation at the Euro PCR meetings in May, now in press and circulation, was the prior PCI subgroup. Amongst patients who had a prior PCI, and there was about 3,600 of these patients, it was a 30% risk reduction in coronary heart disease, death, MI, or stroke. There was a 18% reduction if you also add in ischemia-driven revascularization, a whopping 50% reduction in myocardial infarction in those with a prior PCI. Notice that the curves are diverge very early. Within 6 months, you see a large effect. And a 34% reduction in cardiovascular deaths. So these patients with with prior PCI, but no prior MI or stroke, are very high risk and really benefited from evolocumab. Third subgroup I want to discuss that was presented at the European Atherosclerosis Society in May, now published in circulation in press, is an analysis stratified by lipoprotein a at baseline. First of all, to the left panel, you see having a higher baseline Lp(a) is associated with increased risk of major coronary events, particularly MI and urgent coronary revascularization. Median Lp(a) in this group was about 28 nanomoles per liter. We then did a stratified analysis in patients below 105 nanomoles per liter. That's to the left, panel A, and then to the right, those patients who had an Lp(a) above 105 nanomoles. In blue are the outcomes in placebo, and red with evolocumab. you see that there was a significant reduction in both of these subgroups of coronary heart disease death, MI, or urgent coronary vascularization, to a degree of 35% in those with lower Lp(a) and 41% in those with high Lp(a) at baseline. Moving on now to new developments in triglycerides, I want to share with you some really exciting data from the TIMI 73A and B trials with olezarsen. This is the antisense oligonucleotide that inhibits the ApoC3 mRNA. Important to just review by way of background that reducing triglyceride-rich lipoprotein is really an area of unmet clinical need. We have rather modest to weak agents available for triglyceride lowering, and yet these TRLs are associated with higher CV risk. They're at least as atherogenic as LDL, and when hypertriglyceridemia is severe, it can have direct clinical consequences. Now, in order to understand how this drug and why this drug was developed, I have to go back to a little bit of further kind of basic science about triglyceride and these triglyceride-rich lipoproteins and how they're developed. So in the pathway, a key enzyme is lipoprotein lipase, shown in the blue circle to the left. LPL, or lipoprotein lipase, has an important role in hydrolyzing triglycerides and facilitating clearance of TRLs. And that's good because that keeps the triglyceride level in the blood low. However, apolipoprotein C3 inhibits lipoprotein lipase. ApoC3 is synthesized primarily in the liver. It inhibits LPL, and it causes an increase in triglyceride levels. So what we've learned from genetic mutations of the ApoC3 gene is those patients have lower triglyceride levels and lower CV risk. So wouldn't it be nice to develop a drug that mimics this loss of function mutation in ApoC3? That's what olezarsen is. It's a GalNAc conjugated antisense oligonucleotide that targets the ApoC3 mRNA and thereby de-represses lipoprotein lipase. In other words, it blocks the ApoC3 effect on LPL that allows lipoprotein lipase to do its job. We studied this compound, olezarsen, in 4 randomized trials and then a 5th open label extension that's ongoing. I'm going to share with you the results from the top 2 in severe hypertriglyceridemia, meaning 500 milligrams per deciliter or higher triglycerides. These were identical protocols, TIMI 72A and TIMI 72B, just differed in which countries they were performed and which sites in specific countries. So all patients had to have triglycerides of 500 milligrams per deciliter or higher. They had to be on stable background triglyceride lowering therapy, and they were randomized to one of 2 dosing tiers. And within those strata to placebo versus olezarsen. So it's a double-blind study with 2 different dosing tiers. The 2 doses of olezarsen were 50 and 80 milligrams subcutaneously every 4 weeks for a period of 12 months. Primary endpoint was change in triglycerides at 6 months. And then you can see a variety of secondary endpoints looking at other lipoproteins, looking at analyses stratified by baseline triglycerides, and looking at analyses of achieved triglycerides, and most importantly, the rates of acute pancreatitis, because that's a serious consequence of very high triglycerides. Of course, safety endpoints were looked at as well as changes in hepatic fat. Here from the TIMI 72A trial, the olezarsen at both the 50 and 80 milligrams significantly reduced the triglycerides by about 62 to 72%. You can see that happened quite early by the 3rd injection and persisted out to a year in these monthly injections. Here's the results with TIMI 72B. Notice that the baseline triglycerides was a bit lower. Treatment effect was around 50 to 55% reduction in triglycerides, with the majority of the patients getting very close to 150 milligrams per deciliter, so the upper limit of normal. There were really no important safety signals with regard to events leading to study drug discontinuation with either dosing arm. There were an excess of injection site reactions. Most of those were minor and non-severe. And there were, with a higher dose, some mild elevations in ALT or AST that weren't seen with the lower dose compared to placebo. There was a dose relationship in hepatic fat fraction that was seen on serial MRIs. We are following these patients now another 2 years, and we'll report on that later this year. And there was a modest effect on thrombocytopenia with the higher dose, but no severe thrombocytopenia, no difference in severe thrombocytopenia below 75,000. There was about a 1/4 point increase in hemoglobin A1C, and that deserves a watching. And of course, we'll follow these patients for longer to learn more about them. Now for the real important message here. In these patients with severe hypertriglyceridemia, pooling the data across the 2 trials, so over 700 patients on olezarsen, about half that on placebo, here's the cumulative incidence of pancreatitis in the placebo arm, a serious issue with severe pancreatitis, with severe hypertriglyceridemia. And here in red is the olezarsen effect. You see an 85% reduction in the relative risk of acute pancreatitis. This translates out to about a 5.2% reduction of pancreatitis cases and a number needed to treat in 1 year of only 20. So I want to conclude today's lecture by starting with the Vesalius-CV trial. That was a study with evolocumab in lower risk patients with no prior MI or stroke. I believe that this trial provides us with very strong evidence that we should be more intensively be lowering our LDLs in these patients to less than 55 milligrams per deciliter or 1.4 millimoles per liter. And that applies whether the patient has higher risk diabetes with or without known atherosclerosis, whether the patient had a prior PCI, whether the patient had an elevated lipoprotein a or not. And then the second trials that we talked about, the CORE and CORE2 Timothy 73 pair of trials, olezarsen, which is an antisense oligonucleotide targeting the ApoC3 mRNA, was effective to really lower the triglycerides by 55 to 72%. And remember, these patients all had severe hypertriglyceridemia starting above 500 milligrams per deciliter. There were no serious offsetting safety concerns, but there are some things that bear watching, and we'll be following these patients in the open label extension for longer. And I think the key message here that in severe hypertriglyceridemia, we finally have a therapy that's well tolerated that can significantly reduce acute pancreatitis, in this case, by 85%. So with that, I think I'll bring this talk to the close. And thank you very much for inviting me once again to participate in this important meeting. Bye-bye for now.
Thank you, Professor. Very wonderful presentation. All of us are excited probably to ask you many questions. But let me start with one comment regarding Vesalius trial. I'm an interventional cardiologist, so I'm asking if we started PCSK9 inhibitor as a primary prevention, can we add a reduction in the number of coronary intervention revascularization as an endpoint for this study? Because we expected that the progression of the plaque will be reduced, so definitely coronary angiogram will be reduced.
Yes, that's a very good question. And Brian Bergmark from our group just presented those data at the Euro PCR meetings at the end of May. There was a large reduction in the number of repeat PCI procedures, as well as all revascularizations, including bypass surgery. And he's also working, and I read just on the plane ride back from another meeting, a paper that he's developed on the total lengths of stents used in the trial and follow-up after randomization. And you can imagine if you're reducing the number of PCIs, you're also reducing the amount of stenting patients require.
Professor, we've had multiple drugs for triglycerides. We do use fibrates. we've been using EPA, and a lot of these patients respond very well to these drugs. So which other class of patients would actually be suitable for olezarsen or, advanced therapies of hypertriglyceridemia?
It's a very good question. I'll emphasize that almost everyone, I think it was required by the protocol, and more than 98% were on the existing therapies already, and yet they still had triglycerides above 500. So based on these results, I would say if you cannot get the triglycerides below 500 milligrams per deciliter, despite the currently available therapies, then olezarsen would be the next choice, next step.
Professor, one more point of interest. We interventional cardiologists do a lot of complex PCIs where about 3-4 stents are put, and we want the patients to do well by decreasing the TLRs and restenosis and follow-up. We in our institution and many of our colleagues have also started, at the time of discharge, we give a shot of a Repatha, that is evolocumab, and then try to get the lipids very aggressively down, and probably if patients are comfortable, you could continue it, or 6 monthly, you can change to inclisiran therapy. We wish and probably want to see that their outcome should change, and TLR rates and restenosis rates could decrease further with this proposed model. What are your thoughts on this?
Yes, well, it's a very interesting model of starting it in the hospital. Unfortunately, that has proven difficult to do in the US and many European centers just because of the way the drug is reimbursed. But in any case, the science is correct. I think you should start early and be aggressive. With regard to inclisiran, our group will be announcing the results of the phase 3 outcome trial, Orion 4, looks like early in 2027. So we'll know whether that drug, that molecule, significantly reduces cardiovascular events. I suspect it will be positive. I have no idea. I'm not personally heavily working on this trial. But, all the drugs that profoundly reduce LDL have shown cardiovascular benefits. So I think this strategy will likely be validated once the results of the Orion 4 trial are announced early in 2027.
Yeah, one question, Professor. In your this TLR trial, olezarsen trial, were there any patients on PCSK9 inhibitors or inclisiran?
No, I believe there were not. If there were, it was very, very few, but I don't believe any were, because the target population were patients with extremely elevated triglycerides, as opposed to elevated LDL.
Okay. But these medications also do reduce triglycerides
Yes,
to
but
some
modestly.
extent.
Yes, correct, certainly, but modestly. So there were patients in this trial. As I mentioned, almost everybody was enrolled in the trial on a drug that would reduce triglycerides. But these are modest effects, whether you're talking about statins, ezetimibe, or PCSK9 inhibitors. Their effect on triglycerides are more modest. The ApoC3 inhibitors are reducing triglycerides by 60 to 70%.
That's great. So is Dr. Fayashal online? If the last comment from Dr. Fayashal, and then we'll
I have a question, sorry.
conclude the session.
I just want to share, there's a trial going on in the US on one of the co-PIs. We randomize people after intervention to inclisiran or placebo, called interventional B trial. So we're looking to whether inclisiran post PCI, even there are statins, there is additional therapy by randomization. So we're hoping, and we'll know in 3 years whether addition of PCSK9 is helpful. In addition to their routine anti-lipemic therapy, we don't replace them.
That's a very interesting study. What is the entry LDL? Do you have a LDL minimum?
It doesn't matter what the LDL is. We just randomize them to inclisiran versus, plus being the trial, it's not only free. Patient get $100 per injection when they come for the trial.
Well, it'll be a very interesting study.
I think we have one last question
Just one last question. Thank
you.
Can
you speak loudly, please?
Yeah, hello. Can you hear me? Sorry.
Yes.
Professor Robert, wonderful talk. Just the last question. I think it was already actually addressed. The last two studies that you showed for the severe hypertriglyceridemia were the baseline medications. You mentioned statins, ezetimibe, but I just wanted to address whether any of them were on EPA or fenofibrates. That's my first. And the second, I think that's the only question I have. Sorry. Thank you.
Yes, the majority were on fibrates. That was the most common lipid-lowering therapy, followed by statins and ezetimibe. And as I said, some 99% were on at least one of them. But the most commonly prescribed triglyceride-lowering therapies were fibrates. There were also statins, ezetimibe, and some fish oil use as well. But these are very well-treated patients. Despite being very well-treated, they still had triglycerides above 500.
Just futuristically, where do you think this medication, this olpasiran, is going to be placed? Do you think it's going to supersede EPA and fenofibrates in severe hypertriglyceridemia and supersede EPA in between triglyceride level between 135 to 499? Or do you think it's going to be an add-on? Do you think it's going to take over? I would like to know your futuristic. Thank you very much.
Yes, good question. We will know in the next 16 days. The US FDA is due to give an opinion by June 30th. The company is seeking approval for use in patients with severe hypertriglyceridemia who are already managed with other drugs. And the indication would be to reduce acute pancreatitis. So what distinguishes this trial from the other 4 classes of drugs you mentioned that can also modestly reduce triglycerides is this is the first drug to be clearly shown to reduce the incidence of acute pancreatitis, which is a life-threatening and very serious complication of severe hypertriglyceridemia. So this drug not only profoundly reduces triglycerides, but prevents acute pancreatitis, and that's really the key message.
Professor Fayaz Shal, sir, we also are doing the same in our place, but what we intend to do is, because the PCSK9 inhibitors, evolocumab is supposed to radically decrease the lipid levels faster. What we are doing in our place is, irrespective of lipid levels, one group we give evolocumab and then followed up with the inclisiran. What you're doing is the same, but we are in between addressing it with a fast shot of evolocumab. Do you think the rapid reduction will happen with this? That's what we thought. And follow it up with the inclisiran.
We have this multicentric trial. The first dose they get in the hospital, first dose, second dose in 3 months, then every 6 months. Okay. So we'll know in 3 years.
Okay, thank you.
Yes, I would just point out that the phase 3 lipid-lowering trial studies with inclisiran show early rapid reduction. Now with PCSK9 inhibition through monoclonal antibodies, you have a significant reduction in LDL by day 3. So they're very rapidly acting. But I think honestly what matters is the degree of LDL lowering you have over time. And it doesn't appear it matters how you get there or what drug you use, but it's all proportional. The benefit is proportional to the amount of LDL lowering over time.
Plus, our study is blinded. The labs are blinded. Everything's blinded trials. So we'll know more in 3 years.
Thank you.
So, we thank all the chairpersons and especially the speakers. It's a great work done in this session. Wonderfully heard lectures. They're all recorded, will be available for everybody else who is not available at this moment. Forever, they'll be in the website. So thank you so much. And thank you for being with us. Thank you.
Thank you. Bye-bye.
Thanks. So one last, Dr. Georgie, can you come here? So. Thank you, Dr. Payar.
Thank you.
Thank you. Thank you.
Thank you, Dr. Mittal, for a wonderful meeting.
Yes, thank you and goodbye. Hope to see you in person next time.
Thank you, Robert.
Thank you.
Can we have a group photo, whosoever is here in the hall?
Yes, doctor.
You.
We take terrible cases. We have ECMO, but we don't have impeller. Somehow, because I trained with Dr. Azad.
जमाने से नहीं आया बता जाओ